We are live.
Hello and welcome to the second day of the fourth Global Neuro-Ophthalmology Case Festival. We had a wonderful day yesterday with very interesting cases. So let's dive into the second day and we'll start with the first session. Let me introduce the moderator for the first session. We have Dr. Jasprit Sukhija, who is a professor in the Advanced Eye Care Center at Pediatric Ophthalmology and Neuro-Ophthalmology Division of PGI-MER, Chandigarh, India. He was past president of the Chandigarh Ophthalmological Society and joint secretary of the North Zone Ophthalmological Society. He has more than 130 publications in peer-reviewed index journals and has contributed chapters in books. He is an associate editor in the Acta Ophthalmologica cataract section, and he's a section editor in Strabismus for the Indian Journal of Ophthalmology. He's an invited speaker at various international and national pediatric ophthalmology and strabismus conferences, and a reviewer for many international and national journals. Over to you, Jasprit.
Thank you, Dr. Satya. So we are on to the second day of the Neuro-Ophthalmology Case Festival, and we'll be dealing with the exits. That's the friends, and I'd like to introduce my panel for today, which is obviously they come with a great wealth of knowledge and a unique perspective. So we'll have a good discussion here. So our first panelist is Dr. Paromita Datta. She's an associate professor at Guru Nanak Eye Center, Maulana Azad Medical College, Delhi. Of course, she's done a senior residency in neuro-ophthalmology at a prestigious institute at AIMS, Delhi, and has published 17 publications in some peer-reviewed journals. The second panelist is Dr. Muralidhar. He is the head of pediatric ophthalmology and neuro-ophthalmology department at Coimbatore, India. He's done his fellowship in glaucoma and pediatric ophthalmology from Moran Eye Center and New York Eye and Ear Infirmary. He was a former senior consultant at Sankar Nethralaya, Chennai and Arvind Eye Hospital. He's a keen academician, as we know from his numerous publications and the instruction courses he has conducted. Our third panelist is Dr. Krishna Vaithisavaran. He's a senior consultant ophthalmologist at Mulchand Medicity Hospital, Delhi, and his areas of interest include optic nerve decompression, chemodenervation. He's published over 20 articles and is also the editor of Current Perspectives on Ophthalmology. So with this, I come on to our list of eminent speakers. We have a great lineup today, and I'd like to introduce my first speaker, Dr. Umapati Thirugnam. He's a professor at Duke and National University Singapore School of Medicine. He's also the chief medical officer at visiting Al-Hadi Neuromuscular Center in Iraq. His areas of interest are neuromuscular diseases, neuro-ophthalmology as otology and practice of medicine in the Resource Limiting Center. He's also a visiting consultant to Arvind Eye Care and Research Center in India. Thank you. With this, I'll request Dr. Umapati to kindly share his presentation.
Yes, sir. So I think I can share now. Okay. So thank you, Dr. Satya and team, for the honor of participating in this great session, and also for giving me the responsibility of being the opening batsman of the second innings. So I'm going to tell you a story, quite revolutionary in a way. So let's just straight away start with the story. So this is a 55-year-old man. He was an ex-smoker with poorly controlled diabetes and hypertension and dyslipidemia, and previously had coronary artery disease that required coronary artery bypass grafting. So he came to the emergency department with a sudden onset of binocular and severe visual loss. So let's hear his story.
For my eyes, I kind of like got up from the bed on the left. So when I got up, why is everything blurred? it just went blur. I can see something is there, but I don't know what was that. I can see there's a figure, but that's it. Even when I call my wife, I couldn't see her face. I was asking her, I said, why I can't see your face? Everything is so blur. Something wrong with my eye. Maybe, you know, when you sleep, you know. So she said, okay, maybe you just go to the toilet and wash. So I went to the toilet because it's nearby, because I know. I washed my face and all that. I came back, same thing happened.
So we have a certain form of speaking that we proudly call Singlish. So just to be sure that if people don't understand what this gentleman said, basically he woke up in the morning and developed sudden and severe blurring of vision that allowed him to go to the toilet, wash his face, but he didn't feel better after that. And then he goes on to describe what happened in the toilet.
There, I was trying to look for my soap. I couldn't see, but I noticed a bottle right in front of me. So I couldn't see, took out, smell, oh, okay. I guess
You have to
so,
smell it to know it's soap.
Yeah. So I guess so. So I just watched
So the next morning, it was worse.
It was worse. It was worse. That's why I asked her to help me. I got panic
So he
because I
the
can't.
next morning.
I can see the figure, but I just cannot figure out why. Same like if my daughter
Having some
message,
other disturbance.
I can't read.
Like you
I
can't
couldn't
see.
even see, and it get very frustrated. Like now you're holding your handphone, right? Then you see someone ding ding. You look, oh, I can't see. And I was telling my wife, oh, can I just throw my handphone? Something is wrong with my handphone.
You thought something was wrong with that.
And then I remember you were saying that when your wife was showing pictures that you have taken before on your own
Oh, yeah.
phone,
Oh
he
my
couldn't
God,
remember.
I couldn't
and you
remember.
asked this question:
Yeah.
Who took pictures using my camera?
Yeah, correct. I mean, the camera.
So he couldn't recognize the pictures of his family members in his own camera. So he thought it was somebody else's camera. But he could still see that he was holding his phone camera. Now, this was the visual examination by the eye doctor at the emergency department. As you can see, both eyes, he had only hand movement vision. And the rest of the ocular examination was unremarkable. But his visuals were severely restricted. And then subsequently, when we went on to do a visual fields for him the next day, you could see clearly that he only had small islands of sparring centrally. And of course, the ocular exam was otherwise normal. Now, the next thing is, I've told you his initial story and I told you what happened in emergency department, but I missed out how he came to the hospital. So let's listen to how he came to the hospital.
Okay, good. So then you decided to come to the hospital, right? Can you describe the journey to my colleagues?
Okay, Monday, just one thing I regret was why did I ride my bike with my wife? I putting myself on danger.
Saying that
I'm okay.
he regrets riding the
Not my
bike because he put his wife.
When I rode my bike, I was telling
So
myself,
when you go to the bike, tell me about how you got onto the bike, you got the motorcycle.
okay, my bike
You were
was
saying that the key, you couldn't put the key.
yeah, especially my box where you put my helmet. I mean my helmet. Just to put in the key, I couldn't focus. It's so easy, it's so straightforward, but I just couldn't. So I kind of like hold. You can see the hole with the key. So I just that's how.
So you put the helmet on and then you started riding, and then describe the riding experience.
Okay, the riding experience was okay. It's windy. Lucky thing I was wearing specs, so I mean normal specs. Not so much of pain into the eye. Riding. I've been riding for many years. For the first time, I feel unsafe. Then there's one turning left. Same thing. I was scared because when I turn, I slow down. I was really looking. So really looking. No cars. Then I go up. That's way after that I regret. Went down to the basement, parked my bike nicely, had a nice slot for my bike, parked, put the main stand and everything. then same thing.
So note that he actually parked his car in a basement car park, and this is a car park that he's not used to because he's going to the hospital to take care of himself for the first time, right? So now the wife, who somehow didn't realize how severe the problem was, decided to actually take a ride with him as a pillion rider. So let's see what she says.
What's wrong with you? Are you okay? Because I do not know that the vision, because he never explained to me how the vision was, you know. If he would explain to me beforehand, I would definitely say no.
Sure.
No, but
Yeah.
But you see, and the thing is, I want to ask you a question. So you've seen people who are blind, right? They often walk in a staggering way.
Yes,
They'll
yes.
be groping,
Yes,
groping.
yes.
Did he look like that before?
No. That is the thing. That's why it shocked me, you see. So that's why I say that maybe
So the wife did not notice any behavior that made her suspect that his vision is as badly as affected as hand movement only.
when he walk at home, he don't like touch here and there to walk. That's why I
He
say
didn't look like a blind man at all.
no. So until he parked his bike, okay, at the basement, he's parked smoothly. Maybe he saw the lines, you know,
Yeah.
like okay, maybe he gauged from there. Okay, this is my
So
parking.
underground car park somewhere.
Yes. Okay, so he went down. Okay, the barrier open.
Waiting for the barrier to
It's
open.
smooth. That's why I don't catch. I really cannot catch. And maybe that is his home, so he know his whereabouts. Okay, to the toilet, to the kitchen. Then because I told you he take his
Sure.
own food, you know.
Yeah.
So he know where's the plate. He
Yeah.
knows where there's fork and spoon.
Sure.
So after that, after he do the parking, so he park his bike as per norm, you know, the standing, you know, the two feet.
But this
standing.
is a relatively new place for him, right?
Yeah.
To allow the car park back without any problems at one first attempt.
He park. He. Okay. You have a seat first. I do register for you. Okay, where's the seat? Then I was like, Then then he start to look around. Then I think he know there's a chair. I go there, you sit. So he walked himself because I was looking at him. He walked himself. He touched the chair and then he sit.
So he was able to, he couldn't figure out where the chairs were, but somehow he managed to find the chair and sit down.
My friend
bit.
who's working in A&E, he
Recognizing
don't recognize.
familiar people.
Okay. The voice sounds familiar, but I cannot see her face. So that is why it started like more and more worrying. Yeah. And the worst part, he's just saying, I still cannot see your eyes. So he's still like literally, his face was very close to me, you know.
Okay. So at this point, I want to add that when eye doctors saw him at this point, both eyes, visual perception, he had perception of light and just detects, and he only could detect hand movement in all four quadrants. So you couldn't count fingers, only could detect hand movement, right?
Yes.
Yeah.
Yes.
In all four quadrants in both eyes.
Yes.
So in spite of that, he was able to drive all the way here.
So this is again to reiterate what I showed you earlier. This was the examination at that point when he had described all these symptoms. So the patient and his wife are actually describing what we would refer to as blindsight, which is basically the perception of vision without conscious awareness of the vision. So the localization of such a sign would be the primary visual cortex in the occipital lobe, specifically in the calcarine cortex. And in this particular case, because of the severity of both eyes being involved, we suspected bilateral lesions. And the etiology, we thought, because it's poorly controlled cardiovascular risk factors, a vascular path. So we thought it must be a ischemic stroke. But he did report a very severe headache that started prior to the onset of neurological symptoms. But we didn't think migraine was the number one diagnosis for two reasons. One is because, well, he's a clear-cut vasculopath, and so it would be important not to miss vascular disease. Number two, he did not, in all his 50 years of his life, he hadn't experienced any severe attacks of headache or migraine that would make him fall into the group of complex migrainous syndromes. And lastly, the attack was quite prolonged. As you can see, the deficits remained for almost 48 hours to 72 hours before they started resolving. So with this differential diagnosis, our investigation of choice was MRI. And as you can see, on the left-hand side, the DWI image shows the hyper-intense lesions of cytotoxic edema, which is where the ischemic lesions are. And they are present in both occipital poles. And you can see there are multiple small, almost like showers of small infarcts that have appeared on both occipital lobes. And confirming that they are indeed infarcts, you can see in the image on the right, what we call the ADC image. There's a corresponding black dot where the white dot is on DWI. And consistent with the etiology of a suspected embolic phenomenon, the MRA shows severe stenosis of the right vertebral artery. So our hypothesis was that he actually threw a shower of emboli from his right vertebral artery to his PCAs. And the deficits may have been quite severe at the onset and gave rise to bilateral homonymous hemianopia as well as blindsight. But subsequently, by the time the scans were done about 72 to 96 hours later, only small areas are left behind, because by that time, his visual function had improved considerably, which again is what we see in ischemic lesions. So you can see now his visual acuity has improved a lot, and his fields are much better than on the first day of examination. So treatment for this gentleman would be reiterating the importance of controlling his uncontrolled cardiovascular risk factors and putting him on antiplatelets. Actually, he was already on antiplatelets. We just had to ensure that he was compliant with his antiplatelets. So let's just talk a little bit about this phenomenon of blindsight, where the patients lack conscious awareness of vision, yet their actions indicate some aspects of visual information is being processed. So the way I look at it is that the seeing and the conscious perception of sight, the act of seeing and the conscious perception of sight requires our seeing brain, which is at the back of the brain, and the knowing brain, which is at the front of the brain, to connect. Now, when this connection is disrupted, we can get phenomenology like blind sight or blind sense, where patients are less visually disabled than what the actual visual function dictates. An analogous condition is actually redosh phenomenon, where a patient can actually see movements, but not objects in the field of deficit. And as you can see in the bottom right-hand picture, this beautiful study shows, a functional MRI shows that in this patient with redosh phenomenon, he's actually activating his supplementary motor cortex responsible for detection of movements, even without activation of his primary motor cortex. So this kind of gives you almost a visual picture of what the patient is sensing the movement, but is actually not seeing it. Now, very analogous to this, but contrarian in all its manifestation to these disorders is Anton syndrome, where one does not realize how blind the person is, how blind he himself is. Now, this is due to the awareness of the lack of visual input as processed by the frontal lobe, the knowing part of the brain. And when that is faulty, then you get this feeling that you may not be as blind as you really are. Now, is there another alternate hypothesis other than this disruption of connections? Because I think it's easy to just explain many things away by saying that the connexomes between different parts of the brain, when they're disrupted, you will get various disconnection syndromes. But without a very solid proof, is there any other alternative way of looking at this problem? Well, one other hypothesis is that this hypothesis of islands of spared vision or degraded vision. Now, the best way I can explain this is thinking of an example of a jigsaw puzzle. Now, if you were to do a jigsaw puzzle, now at a critical number of puzzle pieces, you would be able to figure out what the final image is going to be, correct? But prior to that, before you reach that threshold, when the image is suboptimally produced, therefore you can't see the whole picture yet, but you have enough pieces, some other subconscious subliminal functions of vision could still be functioning. So this idea was kind of supported by some functional imaging study done by this group in Harvard, where they showed that actually in patients with injury to the occipital pole, even though it's not activated, even though V1 is not activated, when they do fine sections of V1, they see actually small areas of vision that are spared. So perhaps they are saying that this amount of vision is enough for us to have perception of motion, but like an incomplete jigsaw puzzle, not enough to give you the full beauty of a visual image. Now, and so in summary, I've given you a nice case of a patient with blind sight, and it's a phenomenon that can be caused by lesions in the primary motor cortex, V1. And it is basically a perception without, its blind sight is visual perception without consciousness. And it's believed to be disruption of the connectivity between the seeing brain and the areas controlling the conscious perception of vision. Now, alternative explanation for this is that blind sight is in fact degraded vision. Now, there's quite a lot of work on this. As I mentioned, these two hypotheses have been extensively studied. So this review paper that I've referenced actually gives you a very good discourse on all the various hypotheses and pros and cons and all of them. So I would strongly urge anyone interested in this to look up this paper, which is a free paper in the internet. But perhaps to end off, I would like to just summarize even more simply by saying that one word in the English lexicon seems to resonate with the physiological and pathological processes involved in these disorders of conscious perception. And this word is called liminality. Liminality, okay? Now, liminality is a quality of being in between two places or stages, on the verge of transitioning to something new. It is a state relating to or situated as sensory threshold. It is barely perceptible, but perhaps enough to elicit a response. And since, after all, Satya said this was a festival, I thought I should finish off with some non-scientific ramblings. I would like to call these ramblings lacunes in our soul. So please indulge me. In the dusk between our senses and consciousness, in the twilight lights of our soul, lies the threshold between the mundane and sublime. Explored less than outer space, mysterious more than the ocean abyss. For what we don't look, yet we see. We don't hear, yet we understand. We don't feel, yet we know. We don't sense our ground, yet we stand. We don't perceive our body, yet we balance. Perhaps lapses in this liminal zone between sense and perception explain lacunes in our morality. When we see but don't act, when we hear but are not outraged, when we feel but are not numb, when we know but we faint. The world views that divide and war us. Herein lies the chasm between sensing and being sensate. Thank you very much, ladies and gentlemen.
Thank you, Dr. Umapati, for the interesting case and the showing us the lacunes. Of course, for some discussion, I will request Dr. Paromita to join, please. And Dr. Gordon Plant has raised his hand, so probably he has some comments to make as well. So, can we have Dr. Paromita?
Hello, Dr. Umapati. That was a very interesting case. So I had this query. Did the patient receive any thrombolytic therapy?
No. Actually, for two reasons. One, at first, we didn't suspect stroke. Secondly, the NI score was still high. And as you can see, it was a good decision because the amount of infarcts that finally came out was only small areas. So, you know, they do something called aspect scoring before you. So the CT scan that was done in emergency department didn't show enough infarcts for them to activate thrombolysis. But it's a reasonable thought to think about. But I must say, honestly, at that time, when we first came in, we were working along the line of bilateral visual loss and didn't really think of stroke until much hours later. And also, he came in 48 hours onset of symptoms. So I think these are some of the reasons why thrombolysis wasn't offered.
And sir, how did you distinguish from a functional visual loss?
Well, functional, as you know, nowadays, the way to go through functional disorder is not just to think of functional when we can't explain it, but to find positive signs of functional behavior. So, so this gentleman's story, first of all, in all its nuances, do not show the classic features of functional behavior. So I think that's the main reason why we didn't entertain functional, to the point that even, as I said, even if the scan came back normal, we were happy to call this a possible severe migrainous episode rather than a stroke. But we didn't think it was a thing. I don't know how the others feel, but I think the modern concept of functional disorder is to make a positive diagnosis rather than a diagnosis of a default.
Okay. And generally, is this blind sight phenomenon reversible?
Well, in this case, it is. So I don't know how reversible it is in all patients. But I would think that I know at least for the patients with the bullet wounds in the World War I scenario where the Redosh, the British surgeon who described it, those cases were permanent because they had severe shrapnel injury that went right through the pole of the occipital lobe. So I think I guess it depends on the pathology more than the phenomenology. So if the pathology is migrainous, ischemic, or then there's a possibility of the patient recovering. While if it is a severe neuronal injury, I guess the prognosis is guarded.
Dr. Plant has a comment to make. Dr. Plant? Yeah.
Yes, it's a really fascinating case. I mean, my first impression is that someone who presents with abrupt, bilateral, shall we say, total visual loss with no other symptoms whatsoever, the top of the list there is bilateral occipital infarction. Usually atop of the basilar embolus would be the commonest cause of that in the stroke world. But what he's got is not a complete infarction, because first of all, he made a good recovery, and secondly, it looks more like press on the scan and so on. So he's got the same thing, but it's not complete. And but the problem I have with blindsight is that the term was introduced by Larry Weisskranz, and he's written a whole book on it. I mean, he really did devote his life to it. He called it blindsight because the patient is not consciously aware of the stimulus, and to demonstrate blindsight, you have to ask the patient to guess. So you give them a target and they say they can't see it. Well, they say, well, guess. And they do better than chance by guessing. And this, most of the studies actually were done in one single patient. But what's happened over time, over the century, is that we had kinetic visual fields all the way up to when Weisskranz was working. So patients with Riddoch phenomenon had good kinetic fields. So they were never considered as having blindsight because they had conscious visual perception of movement, but couldn't see static. And we now know this is because of the projections directly from the LGN to V5 to the motion area. So we have a good explanation for the Riddoch phenomenon. But what's happened since then, that everyone's gone to static testing. So these neuroscientists are showing Humphrey fields with all black squares, and they're saying this patient is blind, but they can still see movement, so it's blindsight. Whereas if you tested them with kinetic fields, they would have conscious vision. Blindsight it's at the threshold for those experiments that Weisskranz did. The threshold was really, really high. It's really very, very poor vision. Whereas with the Riddoch phenomenon, as I showed many years ago, you've got normal contrast sensitivity to motion, but the patient's aware of it all. So I think what you've got something here, I would say that this patient is more in this realm of the very, very patchy loss. And possibly if you looked in detail, you might find islands of vision within his visual field. I think he's more in that category, which you've also demonstrated as a possibility. It's not a pure reduct because his Goldman, his kinetic Goldman, he only saw a tiny amount at the center. So it's with a Riddick should have a normal field to movement. So I think this is in the patchy category, and that also fits, of course, as you say, with the recovery and the slightly unusual pathology and so on. But it's an absolutely fascinating case. Thank you.
Thank you. Thank you. So I think, yeah, thanks for the comments. And I just want to, I saw some of the chats, the questions in the chat, and I think I want to re-emphasize that the MRI was done about 3 or 4 days after the admission, when I was doing the video. When I was doing that video, I still hadn't gotten the MR. So it was a case of a negative CT of a patient. And the next day he had recovered his vision quite considerably. And he was telling me historically what were his deficits. And the data that I presented was what was seen in the emergency department eye doctor's review. So by the time I saw him second day, he had improved. So initially, that's the reason why we decided to wait for the MRI, and we didn't push very hard for an urgent MR because the CT was also normal and he was recovering fast. And so the point is that by the time the scan is done, his vision had improved to such an extent that most of the deficits that he experienced at that time probably had a bigger pathological correlate than what is seen on the eventual MR. So the other point that I want to make is that I think Dr. Plant mentions this the definition of blindsight. So I think in this case, if you listen to his story very carefully, there are times when he's able to identify an object, where a phone, right? So he knows it's an object. So I think the modern definition of blindsight is they want to look into the fact whether he's actually perceiving the object, even though he doesn't know he's looking at a phone. So he just saw something that the pictures of somebody in that phone. So the idea that he can understand that's a phone itself means that some perception of sight. Well, there are others who just know that there's something there, but they can't figure out what it is. So that's when a broader term, blind sense, is used, when people feel things going on in that field, and therefore they can get on, so they can drive somewhere because they know there are certain things that are in the peripheral vision that they need to take care of, but they may not know what they are. So I think there is now an attempt to distinguish blind sense from blind sight.
Thank you. No doubt a very interesting case. I mean, for the questions in the chat, I'll just request to please reply them in the chat. And with that, we'll move on to our next speaker. Can you please stop sharing, Dr. Umapati? Thank you. So with that, we'll move on to our next speaker. Dr. Clement. He's a senior consultant neuro-ophthalmologist at the National University of Singapore. He's also the group chief of ophthalmology in National University Health System, which has 4 eye departments, and he's also the director of the Division of Graduate Medical Studies. With this, I'll request Dr. Clement to please start his talk.
Right. Can you see the slides?
Yes, they are
okay,
clear.
That's great. Okay, right. Good afternoon, good morning, and good evening to everyone. And once again, my thanks to Satya and the organizers for this very kind invitation to be part of this case festival. It's always very exciting to look forward to this. The case I'm presenting is a 54-year-old woman who had a 1-year history of progressively worsening binocular horizontal diplopia and left eye redness. And apart from that, there was not much else except that she has a pretty extensive medical history of diabetes, high blood pressure, heart disease, arterial disease, and renal failure or renal replacement. So really bad vascular path. When she presented, these were her eye movements. You can see there's some limitation of adduction of the left eye and of elevation as well. And the eye is red, and on measurements, she had a little bit of she had a mild proptosis. The visual acuity was reduced, and the intraocular pressure was high. There was no afferent defect and no anisocoria. Visual fields were pretty normal. And the fundus exam, other than the fact that she'd had some panretinal photocoagulation and some other signs of diabetic retinopathy, was otherwise unremarkable. The eye was red, congested with tortuous vessels. She had an MRI done, and this shows that the the superior ophthalmic veins not terribly enlarged, just maybe mildly, but there is some slow flow in the left superior ophthalmic vein. And this is again seen here, but what is also better seen here is that the muscles in the left orbit were all quite thickened. And this seemed to suggest that there is some venous congestion going on in the orbit. So at the time, the thought was this is probably due to a carotid cavernous fistula. And she had a MR angiogram, as well as she subsequently had an MR angiogram and a catheter angiogram. But at the MRI, it was also thought that the left cavernous sinus was slightly hyperintense on the T2 images as well. However, the MR angiogram and the subsequent catheter angiogram did not show a carotid cavernous fistula or cavernous sinus thrombosis. So while waiting to figure out what was happening, she had, of course, treatment for the raised intraocular pressure, which seemed to help with the visual acuity somewhat, but the intraocular pressure did not really come down very satisfactorily with 2 drops. Subsequently, it was suggested she have a CT venogram instead, and this CT venogram seemed to show that the blood vessels on the left side of the brain are a little more congested, and looks like a bit more vascularity on the left side of the brain. And that was when we had some additional information pop up in the history, and that is this poor lady has had a history of brachiocephalic arteriovenous fistular stenosis requiring fistuloplasties and balloons. Now, and this had happened a couple of times already by the time she had presented to us. So we asked for, these are pictures of the catheter angiogram, and you can see again the increase in vascularity on the left side of the brain. This is the internal carotid injection. You see the right side and the left side. Let me just play that again. And the left side looks like there's an increased vascularity. And this is the external carotid artery injection. And again, there's an increased vascularity over the face as well. So we then, with that history, we wondered if there was something that was perhaps causing blood to flow up the internal jugular instead. And we asked for an angiogram to have a look at the blood flow in the brachiocephalic vein, where we suspected that something might be happening. And this is the cephalic vein injection. And if you just watch this area, I don't know if you can see my pointer, but somewhere around where she's had the wiring over her chest, you can see that the blood does not flow down into the superior vena cava. It kind of stops, if you follow the injection, just somewhere about here, right? And there is a lot of flow then back upwards to the internal jugular vein and to all the other venous plexuses around the head and neck. So just one more time. And then you can see that the blood flow is not, the blood does not continue to go down towards the internal jugular vein. So the diagnosis at this point was that this was a left brachiocephalic vein occlusion with reverse flow into the internal jugular vein. She then subsequently underwent angioplasty and stenting of the brachiocephalic vein. And this a picture of the balloon that was used to try to dilate up the brachiocephalic vein. And this is a very nice, I want to thank my interventional radiology colleague for these very nice videos of the stent being deployed into the brachiocephalic vein. Oops, yeah. And with the stent having been now nicely deployed into the brachiocephalic vein, of course, we hope that the flow will be restored. And if you look now, you can see that the blood now flows all the way back down into the internal jugular, and there's no more reflux back upwards onto the flows down to the jugular, the superior vena cava, and does not flow back up onto the internal jugular vein again. And so that was a nice stent with good flow after that. So 5 months after the intervention, when she pitched up again for a review, the intraocular pressure was normal without medication, visual acuity was good, no more proptosis, motility full, and the eye was no longer red. So this is a case of brachiocephalic vein obstruction, and I mean there are many different causes that are listed in the literature. But this patient had none of these other than perhaps the fact that she had a coronary artery bypass graft in the past, but there was no tumor or no specific reason for there to be a occlusion. She had not had any manipulation there other than the arteriovenous fistula, which was really in the left upper arm. What we surmised was the reason for this flow back up into the internal jugular vein is that there was some aortosternal compression, venous compression, where there's a bit of an anatomical narrowing as the brachiocephalic vein passes between the sternum and the aortic arch. And in a normal circumstance, with the low flow, in a low flow system, this doesn't usually cause a problem, and you don't see any of these, anything like a superior vena cava syndrome. But in this case, because of the AV fistula, there was a high flow system, and basically the narrowing there could not cope, and the blood instead started to back up into the internal jugular vein. Interestingly, there are reports of similar cases in the literature, and I deliberately bolded the years of publication because it seems to be a case every 8 years, and so this is about the 8th year since the last case that we're seeing yet another case of this. And so I guess for me, the learning is sometimes the neuro-ophthalmologist, we really do need to think like the plumber. And if the pipe is blocked, you've got to keep looking until you find where the blocked pipe is. And with that, thank you very much for your attention.
Thank you, Dr. Clement. Another fascinating case to look at. I mean, so as you're saying, it's a high flow fistula, but is it that, I mean, the presentation can be a bit mild in these cases? Because I thought that it's always the eye should be very angry looking or very aggressive in these high flow fistulas.
So I think it only happens if you have the flow back up into the internal jugular vein. But I mean, most we have so many renal failure patients with fistulas, this does not usually happen. So we thought that this was simply because there was already a little bit of a narrowing in the chest, and the poorly functioning fistula essentially caused the high flow, and because the narrowing could not cope with that high flow, we just have a backflow into the internal jugular. I see Gordon has a Dr. Plant has a question or a comment.
Dr. Plant and Dr. Murli, please, he's the panelist.
Yeah, I have a comment and a question for Dr. Clement. So the comment is for the audience that usually an AV fistula is created by the nephrologist so that they can keep accessing the veins every now and then the veins get dilated. Dr. Clement, you could do all this catheter venography and catheter angiography because you probably were in a multi-specialty hospital with a good access to an interventional radiologist. For the rest of us, I mean, if we get a CT angiography or a CT venography which doesn't show a CCF in the cavernous sinus, can we request the radiologist to extend a CT venography or angiography into the chest? Would that be sensitive enough to pick up these fistulas? Not these fistulas, these kind of brachiocephalic vein thrombosis and a retrograde flow, would a CT angiography or a CT venography be sensitive enough to pick this up? Or would you still recommend that we refer to an interventional radiologist and coordinate with them for a catheter venography and angiography?
Yeah, I think you would need something dynamic like a catheter angiogram to kind of show where the flow is really blocked up, because there is no real point. There was no real in any of in the investigations that were done, and there were some CT scans of the chest and all that we could not really reliably identify where the obstruction was. So it was only on repeated investigation that we found it. And yes, I do acknowledge I'm fortunate to be working with some really good interventional radiologists.
Dr. Veena, any comments?
Well, no, it is a very nicely documented and well worked up case in terms of doing the angiograms and all. My only thing was clinically, did she have any dilated veins over the neck or anything like that?
Yeah, it did not really look like she had a lot of dilated veins on the neck, and I must confess that we were not very good physicians. We didn't look for a raised jugular venous pressure or pulsating, internal pulsating jugular veins, and we kind of focused a little bit too much on the eye and the orbit, and the eye movements, and didn't really think that we should look at the neck, and that might have actually given us a much better clue of where everything was going wrong, and it was really just a bit of a guess when she said, "Oh, I've had these treatments done to my AV fistula before," and that made us wonder whether there was some obstruction on the left side, because the fistula was on the same side as as all her symptoms.
So she didn't have any congestion over the neck area and all, which is
not obviously. I mean, it was not more hyperemic. It was not more swollen. Although in retrospect, looking at the MRIs, actually the soft tissue around the face on that side does look a bit more swollen.
Dr. Plant?
Yes, it's a really interesting case. I just wanted to say that the findings on the MRI orbits were wrong for a dural arterial cavernous fistula, because in that situation there is high flow in the superior ophthalmic vein, and we diagnose this, as you know, with ultrasound, because there is high pulsatile flow in the superior ophthalmic vein. And this is also why, paradoxically, when you have high flow in a vein, this predisposes to thrombosis. So SOV thrombosis is one of the complications of these fistulas, and that's because on Virchow's triad, you get damage to the endothelium of the vessel, which gives rise to thrombosis. So if you'd done an ultrasound, they would have told you that there was low flow and congestion, venous congestion. The other thing to remember is that we see this, of course, with these fistulas, but also quite often the jugular vein is tied off, particularly with neck dissection for malignancy and so on. And sometimes I found the neurosurgeons, they're not neurosurgeons, the surgeons don't even record in the notes that they've done this. So then someone goes back and goes a little bit later, goes on and does the other side and ties off two jugular veins. And that's when you get raised intracranial pressure for sure. But these arterialized veins from fistulas are, of course, much more common. It's also very interesting how severe the episcleral venous hypertension was, and how it was completely relieved with the treatment, which was fabulously done.
Thank you. Yes, I see a number of comments in the chat box as well, and yeah, I think Satya has the best comment there. So this is probably something that occurs reasonably frequently, that we ought to recognize it, but maybe we don't write it enough so that everybody recognizes it.
Yeah, I mean, that's right. So
maybe we should pass a poll around, and maybe we should Satya, we should pass a poll around and say, okay, how many of you have got a case? and then we'll collect them, and then maybe we'll do a big nice big report out of the Neuro-Ophthalmology case festival. That might be fun.
Sounds good.
Thank you, everyone.
Yeah, that's food for thought. So if there are no more questions, we move on to our next presenter. And yes, so our next presenter is Dr. Mariana De Virgilis. I'm sorry, the pronunciation is wrong. She's professor and head the teaching and research department at the hospital Pedro Laglesi in Argentina, and also at the Hospital University in Argentina. She is the Young Ophthalmologist Coordinator for Argentinian Ophthalmological Council. She's also the director of the concert course of Argentinian Ophthalmological Council. She's also received the Peter Savino International Fellow from NANOS, and she's also the reviewer for the Journal of Neuro-Ophthalmology, both Neuro-Ophthalmology and Neuro-Ophthalmology. Thank you. With that, I'll request to please share the presentation.
Thank you for the invitation. I'm sharing. That's it. Thank you, Dr. Satya, for the wonderful organization. I am honored to share this presentation with Dr. Gordon Bland. He helped us a lot with the case. I have no financial disclosure. Let me introduce you to a male patient. He is 52 years old. He went to the emergency room due to an episode of bilateral horizontal anxiety, cerebophthalmia, and increased diuresis, horizontal diplopia. No fever, no recent immunization or other symptoms. Past history, cardioversion 2004, radioablation 2014, medication, flecainide, 100 milligrams, twice a day. The day before the episode, he was fumigating roses with vaporizer, which contained glycoxane, chlorpyrifos, cypermethrin. He spent hours with the product in his face, hair, clothes, and eyes until he washes that. He washes that out. On day 1, the examination shows vision 20/20, pupils mid-range, poorly reactive, and if you look now, OD impaired abduction. The rest of the exam unremarkable. What we know about chlorpyrifos, organophosphate, anticholinesterase inhibitor, acute poisoning results mainly from interference with the acetylcholine neurotransmission pathway, leading to a range of symptoms from mild to severe poisoning. Mild poisoning, eye watering, increased saliva and sweating, nausea and headache. Intermediate exposure may lead to muscle spasm or weakness, vomiting, diarrhea, and impaired vision. Severe poisoning includes seizures, unconsciousness, paralysis, and suffocation from lung failure. Cypermethrin is an insecticide. Acute poisoning results mainly from an excitotoxic effect, but bind poorly to human sodium channels. Paresthesia, itching, burning, dizziness, nausea, vomiting, and muscle twitching. Seizure, death. What is your diagnosis? Because of the exposure history, organophosphate intoxication, but our patient had mydriasis. Blurred vision, something like urinary incontinence, anxiety, definitely. But in Argentina, we have to keep in mind stramonium, because it's a weed that is abundant in our environment with leaves similar to the fig tree and sometimes more than a meter high. It contains atropine, scopolamine, manifesting as anticholinergic syndrome. And here we have an article from Dr. Gordon Bland, 2023, anticholinergic syndrome, blurred vision, and headache. And on day 2, examination shows eye movements globally worse, symmetrical, pupils more dilated, minimal light response, no effect of fatigue, negative eyes test. Visual field, unremarkable. MRI, MRA, MRB, normal. The toxicology service insists that symptoms are due to toxicity, but Dr. Gordon Bland wrote, I have looked at the videos again, definitive ophthalmoparesis symmetrical. On the second day, I presume no ataxia or areflexia. We did write up a Miller fissure that was ocular only, and I have seen with pupil involvement. Here we have the clinical case that Dr. Gordon Bland mentioned as 1996. The main dilemma is how typical cases where one or more features of the triad is absent. The presence of CQ1B antibody can provide important diagnosis information in atypical cases of ophthalmoplegia where there are no other clinical, electrodiagnostic, or imaging findings to suggest the diagnosis of Miller fissure. This is an interesting case report and literature review. Two cases, the first one similar to our case. Tonic pupil in Miller fissure was first described in 1977. Fixed dilated pupils are a result of involvement of preganglionic pathway parasympathetic from Ettingeric westbound nucleus to the ciliary ganglion. Tonic pupils are thought to be due to the damage of ciliary ganglion or short ciliary nerves. On day 6, these photos shows the difficulty in ocular movement in almost all cases. Pupils might range poorly reactive, no effect of fatigue, negative eyes test. On day 14, the pupils are already reactive, but the diluted pilocarpine test was positive. Eye movements, almost full, some problem with the abduction in OD.
Rojo, verde, rojo, rojo.
Clinical lab,
verde,
normal.
Rojo.
A month later, pupil and eye movements, normal. Orthophoria, orthotropia, waiting the final lab results. Three months later, normal pupils and preserved ocular motility can be observed. And the latest lab test shows CQ1 antibody positive. So, take-home message, the first impression is not always the right one, or yes. Intoxication was the cause or coincidence. Bilateral tonic or dilated fixed pupils can be a manifestation of Miller fissure, and pupillar involvement can occur in approximately 50%. Anti-CQ1B antibodies are useful to confirm the diagnosis in atypical cases. Intravenous immunoglobulin is the treatment of choice. So now, I leave you with in the best hands with Dr. Plant. We'll be answering all your questions.
I mean, he can answer any questions. I mean, there's no doubt about that. So, I mean, very interesting case without any systemic problems. And yes, of course, you have the, you can say the doyen of neuro-ophthalmology, Dr. Gordon Plant, I mean, who just picks it up at just a presentation. But it's quite atypical to have such things. And what are the, I'll like to start off with asking, like, what are the other, I mean, how would you approach this case with the ophthalmoplegia, diplopia on the first day, and probably no diplopia because it's symmetrical on the second or third day, and without any systemic complaints? So it kind of becomes quite a complex thing for the ophthalmologist from the neuro-ophthalmology point of view. So how do we approach this? I mean, because you had some organophosphorus problems as well. He was, so Dr. Plant, your views?
Well, I think we don't know that the organophosphates had no role in this. It's a bit of a coincidence. And of course, we don't know what the trigger is for Miller-Fisher. But the recovery was very typical of Miller-Fisher. I personally have never treated a single case of Miller-Fisher syndrome. They tended to be young people, and my experience was that they all made a full recovery. The only case I ever treated was an elderly man who was in fact already had a peripheral neuropathy and was under the care of Sumner in I think Sydney with his peripheral neuropathy. So I thought he was particularly vulnerable to do badly. So we gave him IVIG. But other than that, I've never treated a case. And I have never personally seen a case with pupil involvement, but I know that they are reported. And when you look at the anti-G1B antibodies and the relationship to Campylobacter infection, you also have to think to ask these patients if they've had an episode of diarrhea prior to this. And I remember one chap who he and a number of other people were ill after dining at a club in London, which is well known, and I won't mention it. And he got Miller-Fisher and did manage to sue this club but he also didn't get any treatment, and he also made a full recovery. So I don't know if anyone has any different experience than that.
Dr. Krishna, please. You're muted.
So, yes, indeed. Thank you. Yeah, very interesting case actually. And looking at the sequence of events with an organophosphorus exposure. So I think the etiopathogenesis would somewhere lie in the organophosphorus poisoning, because we know that the organophosphorus poisoning could well be, you have an immediate cholinesterase effect, and then you have the intermediate syndrome and a delayed polyneuropathy, which is very commonly seen with organophosphorus poisoning. This would fall into the intermediate syndrome, and as we have seen, I mean, the intermediate syndrome has got multiple issues because the exact pathogenesis is known, it's not known. So you could have a parasympathetic-like picture, you could have a parasympathetic kind of a picture. So both kind of a picture could happen. But clearly, there is a immune mechanism there too. And we know that OPs do alter the immune, there is an immune deviation with organophosphorus poisoning, and that would give rise to enhanced risk of multiple immune syndromes, including Guillain-Barré and first Miller-Fisher being a variant.
Yeah. I mean, the fact that the acetylcholinesterase levels were normal,
yes,
does rule out this as being the primary cause, but of course we can't be sure. Yes, the question is whether it had some role in precipitating the rest of the syndrome.
Response seems very typical. I mean, like of Miller-Fisher. I mean, the way he recovered, but then because if it had been an organophosphorus-induced polyneuropathy, you would not see a recovery like this, and I mean, it would be very difficult to actually have a response like that. And second, I mean, I think the role of, I feel that the role of an NCV or an EMG would have, changed the diagnosis as to whether they work, because we know that in GBS there would be, particularly if you use the NCV could differentiate between the polyneuropathy induced by the organophosphorus and the Lambert-Eaton syndrome, which would recover with higher.
Yes, we find that in Guillain-Barré and organophosphorate inducing that. I found some papers, 7 papers in the literature, and it's true. It's supposed maybe some linked What do you think, Dr. Gordon?
In fact, we typically do, at least in the organophosphorus poisonings that we get in our hospital, we would get the esterase levels done just to predict the neuropathy, which could follow later on, and also predict the intermediate syndrome, which is where you lose
Yes.
most of our patients with respiratory paralysis. So this is something which is that seems so much like an organophosphorus induced neuropathy.
I understand the point. I can show, if you want, I can share the I'm sorry, where is my presentation? No, I can show. I have I want to show because I have that papers that you mentioned, and it's true. Let me see if I can share. I don't know what do you think about Dr. Gordon, but I have in my presentation here. I got it. I have in my presentation. What are you talking about? Here. It's because, are you talking about, sorry, are you talking about HLA, the air expression may therefore a good indication for evaluating the acute organophosphorus pesticide poisoning? I have that article, and it looks like a good explanation. And with this case report also, they say that improved with plasmapheresis, so maybe an immune deviation is causing it. Pathogenesis is supposed to be a direct toxic effect. We do not an electromyogram, and maybe it's a good form to distinguish that trick. But I don't know if it's what are you asking about, but I think the thinking is going to that point.
Yeah, there may be a link there. And another issue just to bring up is I'm rather a purist about tonic pupils, because tonic pupils are actually irreversible.
Yeah.
Because they are due to aberrant reinnervation, where the sphincter muscle, the iris sphincter, is now innervated by nerves that should be going to the ciliary muscle. So you get pupil constriction when the patient converges, but not when in response to light. Of course, presumably in response to light, there's a few feeble fibers there that are desperately trying to accommodate. But that's permanent because it's sorry, someone at the door. That's permanent because it's aberrant reinnervation.
Particularly in the intermediate syndrome, you could have both a parasympathetic component as well as a, basically because of the overexposure of the cholinergic receptors. So they could actually have a down distance, and actually you could have a parasympathetic kind of a picture in the intermediate syndrome, and you can actually have meiosis in patients who are in respiratory paralysis because of organophosphorus poisoning. So this is quite, it's quite not what you actually expect, but you do get this kind of a constricted myotic pupil in the intermediate period of organophosphorus poisoning.
Yes, but a tonic pupil is one that does not respond to light, but does respond to near. That's the difference. That's the difference.
Yes.
Yeah. So thank you. I think we've had some wonderful session, and we've had some incredible speakers who've given us valuable insight to this, and the discussion was marvelous here, and the conversation and the discussion should go on. So with this, I'd like to conclude by saying thank you to all our speakers and panelists of the session. And I'll now invite Dr. Satya Khanna to please take it forward. Thank you.
Thank you, Jaspreet. And let me introduce the moderator for the second session for today. And that is Dr. Himalini Samant, who is a director at Acura Site Daycare Center in Mumbai. And she's also been an honorary associate professor at JJ Hospital for 19 years. She has a special interest in pediatric ophthalmology, cataract, strabismus, and neuro-ophthalmology. And she has presented papers nationally and internationally. She had a best paper at the SARC conference on myasthenia gravis. And she is a co-author of DK Notes, a book on ophthalmology for undergraduates. Over to you, Himalini. Himalini, you're there?
Yeah, I'm there.
Okay.
I'm just sharing my screen. Okay. Hello, everyone. Can you hear me, Satya? Am I audible?
Yes, you're audible.
Okay, so we have the next session now, and we have very good speakers. But first, I'm going to introduce our panelists. So we have Dr. Jenil Sheth. Dr. Jenil leads the Pediatric Ophthalmology and Strabismus Department at Shantilal Sanghvi Eye Institute, Mumbai. And he's a very passionate teacher. He's trained many long-term fellows. He's co-authored several books and has 17 PubMed indexed publications to his credit, in addition to some in international journals in the field of complex strabismus and neuro-ophthalmology. He's also presented several papers at national and international conferences and has won 2 national awards. The next panelist is Dr. Preeti Patil, who is the professor of ophthalmology at the Pittsburgh ophthalmology at Pittsburgh and faculty at the Children's Hospital of Pittsburgh in USA. She was trained in India and completed her residency at Shankar Nethralaya. She, in addition to that fellowship, also did another fellowship at the University of San Diego, California. She has been in the clinical faculty with pediatric ophthalmology and neuro-ophthalmology at LV Prasad in India, Hyderabad, for the last 7 years before she moved to Pittsburgh. And her research interests include pediatric neuro-ophthalmology, strabismus, and CVI. And our star panelist is Dr. Pradeep Sharma, who doesn't require any introduction. He is currently working at Center of Sight in New Delhi. He's received several awards, but I'm just going to highlight a few. That is Athavale Award in the 2002 All India Society and the Colonel Rangachari Gold Medal in 1984. The Gillies Lecture in 2024, is a visiting faculty in Orbis, is member of several associations, including the American Association of Pediatric Ophthalmology and Strabismus, and has been the former president of SPOSI, and has several papers to his credit in national as well as international journals. The first speaker today is Dr. Daniel Gold, and he's an associate professor of neurology, ophthalmology, and otolaryngology, head neck surgery at the Johns Hopkins. He maintains active clinical practice, seeing patients with vestibular and neuro-ophthalmic conditions. He's also heavily involved in education of residents and fellows, giving them frequent lectures on topics related to his subspecialty. He's written a book in neuro-ophthalmology and neuro-otology, which was published in 2022. So over to you, Dr. Daniel. Is Dr. Daniel there?
Yes, I'm here. Can you hear me?
Yes, sir.
Yes.
Excellent. All right. I was just in actual India a couple weeks ago, and it was delightful. So I'm happy to be back in virtual. Unfortunately, I'm in Sweden right now at a conference, borrowing a room for a couple minutes, and my camera is not working, and I've not figured it out. So I'm not trying to hide anything, I promise. Let me share my screen here. So this will be very different than the last excellent talk. And let me share my screen, optimize for video clip.
Oh, sometimes, Dan, if you push F7, it might come on.
F7. Yeah, I will not right now. It's not doing anything right now. So I'll try it later. Apologies. So let me just get this out of the way, and hopefully you can see my screen. And so I'm going to talk about oscillopsia ×2. So this is really kind of harping on a bedside examination maneuver that's pretty easy to perform, easy to interpret, that many people might not be aware of. So this will be very, very clinical and very, very practical. So this is a 75-year-old woman with progressive imbalance for 5 to 10 years, presenting with oscillopsia and diplopia. And oscillopsia number 1 is a so-called sitting oscillopsia, meaning that it's independent of head movements. Dr. David Newman-Toker, one of my mentors, coined the terms sitting or walking oscillopsia, meaning that if you're sitting, you're not moving your head, and you have kind of a spontaneous oscillopsia. We'll talk about the different kinds, but this was one of her symptoms. And here's her examination. And in right gaze, she's got the target's a little bit close. She's got an exo, but she also has a right hypertropia. And her diplopia is in lateral gaze. And in left gaze, she has a left hyper, which was also a left hypertropia. So a right hypertropia in right gaze, a left hypertropia in left gaze, consistent with an alternating skew deviation, causing diplopia in lateral gaze. Good, look to the left. She also had a gaze-evoked nystagmus, also with a downbeat component. So it's a so-called side pocket. It's a combination of a horizontal gaze-evoked with a downbeat nystagmus, kind of giving it an oblique trajectory. And she experienced maximal oscillopsia, sitting oscillopsia in lateral gaze, although she did experience some oscillopsia in primary gaze due to a little bit of downbeat nystagmus that she also had. Unfortunately, I was unable to get a good pursuit video for her, but this is another patient. Whoops. This is another patient with the same finding of very saccadic smooth pursuit. So it's just saccade, 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 chop, chop, chop. Because she has no smooth pursuit system, essentially, she's substituting saccades for smooth pursuit. That's what gives it that choppy appearance. So she also had, in addition to an alternating skew, gaze-evoked and downbeat, saccadic smooth pursuit. Taken together, this is highly suggestive of a cerebellar problem, specifically localizing to the flocculus and paraflocculus, if you wanted to get into the nitty-gritty. So oscillopsia number 1, her sitting oscillopsia, was explained by her gaze-evoked and downbeat nystagmus. She had an oscillopsia number 2, a walking oscillopsia, which was dependent on head movements. So the vestibulo-ocular reflex is responsible for stabilizing your eyes and stabilizing your vision when your head's in motion. If you have no vestibular system, this is what the world looks like when you walk down the street. So this is a walking oscillopsia. How can we explain that? This is the maneuver. This is the point of this whole PowerPoint, is the visually enhanced VOR. Why is it the visually enhanced? Because the patient is using their visual system, they're fixating on the target, and this is a combination of smooth pursuit and the VOR. It's slow enough, and you can see in slow motion, saccade, saccade, saccade. Saccade, saccade, saccade. This should be very, very smooth. And so this is a saccadic visually enhanced VOR. And because the visually enhanced VOR is a combination of smooth pursuit and VOR, if either of them is intact, the VVOR is going to look smooth. So if it is saccadic, that means that both of them are impaired. We already know that her smooth pursuit is saccadic. So without even checking a head impulse test, what can we say about her VOR, her vestibulo-ocular reflex? It's going to be really, really bad. She almost certainly has bilateral vestibular loss, given her saccadic VVOR, which takes less than 10 seconds to perform And it's pretty easy to interpret. The only caveat here, I would say, is remember, a lot of these patients are going to have gaze-evoked nystagmus as well. So if you bring them a couple of degrees too far out to the right or too far out to the left, you're going to see a little bit of gaze-evoked. So you're really looking at the movement here in the middle, gaze-evoked. In the middle, chop, 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 gaze-evoked. So if we were to do a head impulse test on her, we would see this finding. This is an abnormal head impulse test. This is a high frequency, high acceleration movement that is too fast for the smooth pursuit system to keep up. So the visually enhanced slow VOR pursuit contributes to that significantly. This fast head impulse test is way too fast for the pursuit system to keep up. So this is the way that we isolate the vestibulo-ocular reflex. And here we see bilateral abnormal catch-up saccades. So the head is moved, the eyes go with the head, the patient realizes that they've lost the visual target, and they have to make a corrective saccade. That catch-up saccade is what tells us that there is vestibular loss, which in this case was present on the left side and the right side. So this is a bilateral vestibular loss. And we can do something called the video head impulse test, where we can actually quantify the vestibulo-ocular reflex. As opposed to saying, I see that corrective saccade, we can actually give it numbers, gains, the ratio of the eye movement velocity, the output, to the head movement velocity, the input. And all of these should be 1, and they're all much, much lower than 1. So in this patient who has vestibular loss, we can see that there's a vestibular loss in the planes of all 6 semicircular canals, right? You don't just move your head horizontally, you move it vertically, you move it in different planes. So oscillopsia number 2 in our patient is a walking oscillopsia due to her bilateral vestibular loss. Again, I really want to emphasize the VVOR. This is the point of this presentation. A saccadic VVOR means immediately in the first 5 seconds that pursuit and the VOR are both impaired. A normal VVOR means that either both pursuit and VOR are intact, or at least one of the two is intact. Okay, so if it's saccadic, you automatically know that you have involvement of the pursuit system, usually due to cerebellar dysfunction, and you have vestibular loss. It's that easy. So what is a condition that this patient has that all ophthalmologists and neuro-ophthalmologists should be aware of that can cause pursuit, dysfunction, and VOR loss? Something called canvas. Cerebellar ataxia. And what are some typical cerebellar ataxia signs? We see gaze evoked and downbeat. We see saccadic smooth pursuit. We see spontaneous downbeat or downbeat that is mainly in lateral gaze. That's representative of the cerebellar ataxia. I don't have any, I'm a very visual person, and I have a picture of some legs here. I don't think this patient actually had a neuropathy, but the N is for neuropathy. And the VA is for vestibular areflexia. That's the bilateral vestibular loss syndrome. Canvas. Be aware of this entity because it can cause oscillopsia ×2. Cerebellar ataxia, neuropathy, vestibular areflexia syndrome. Patients might present to you with downbeat. Patients might present to you with a walking oscillopsia. So be aware of this diagnosis. And again, canvas patients can have double the oscillopsia, and they can have both walking as well as sitting oscillopsia, which this patient had. So the identification of the RFC1 gene expansion as the cause of canvas was just described in the last couple of years. So the disease phenotype really has been expanding. We always thought that you had to have very severe cerebellar ataxia and severe vestibular loss and severe neuropathy, but that might not be the case. It might just be causing cerebellar ataxia and downbeat nystagmus. It might just be causing bilateral vestibular loss and walking oscillopsia. Other conditions with a saccadic VVOR, and again, when I say saccadic VVOR, That's not specific to canvas, although it is a common finding. But what we're talking about are patients who have both cerebellar dysfunction and vestibular dysfunction. Wernicke's encephalopathy can have both. Spinocerebellar ataxias, including type 3, type 27B, which is probably a very, very common cause of downbeat nystagmus that's emerging in the last year or two. Superficial siderosis, or immune-mediated or paraneoplastic disorders, anti-Hu, anti-Kelch-like protein 11, anti-glutamic acid decarboxylase, among others. So if I have 2 more minutes, I probably don't have 2 more minutes. Should I continue and talk about one other clinical finding or just end?
I think yes, so you can go ahead.
Yes, please continue.
Okay. So normally, a patient, this is a patient, a young woman with cerebellar ataxia who has saccadic smooth pursuit. Normally, that patient who has saccadic smooth pursuit is going to have just as bad, equally saccadic vestibulo-ocular reflex suppression. What does that mean? This is a combined eye head movement. This is just rotating her in the eye chair with her outstretched thumb. She's looking at her outstretched thumb, and the eyes shouldn't move in the orbit. And we can see saccade, saccade, saccade. This is a reflection of her impaired smooth pursuit system. And so saccadic smooth pursuit and saccadic VOR suppression go together like peas and carrots. They're usually both normal or both abnormal, as they were for this patient. But what if, and I want you to follow the light of the camera with your eyes. This is smooth pursuit. This is a patient with cerebellar ataxia, and again, it's saccade, saccade, saccade. Saccade, saccade, saccade. A little bit of gaze evoked when you get too far out to the right and to the left as well. Good. Follow the camera with your eyes. And now this is a combined eye-head movement. Now I'm doing VOR suppression. It is much, much better. Every once in a while, she kind of loses... right at the light. Loses the light, but when she's looking at the light, there's no movement there. This is normal VOR suppression. What does that mean? So she has saccadic pursuit and normal VOR suppression. This means that the patient has no VOR to suppress. She has vestibular loss. So if a patient has both cerebellopathy and vestibulopathy, and this is a patient with anti-GAD encephalopathy, the patient is going to have a saccadic VVOR, saccadic pursuit, normal VOR suppression because they have no VOR to suppress, and an abnormal head impulse test. So the beauty of the saccadic VVOR, visually enhanced VOR, is that you can predict the findings for 2, 3, and 4 without actually doing them. Just simply doing a 10-second test gives you so much information when it's abnormal. Take-home points. Evaluate the VVOR in all patients with imbalance or oscillopsia. If abnormal, you immediately know that both pursuit, which is often cerebellar, and VOR, the vestibular system, are impaired. If normal, you know that one or both of the systems work, and then you can evaluate pursuit and the VOR individually. Consider canvas cerebellar ataxia, neuropathy, vestibular areflexia syndrome, and related conditions in patients who have an abnormal VVOR. And we wrote about this in a little updates in Neuro-Ophthalmology from the Neuro-Ophthalmology issue of Current Opinion in Neurology last year. So this is just a couple paragraphs, all you need to know about Canvas if anybody's interested. And as always, all of my videos and much more can be found in my collection through the North American Neuro-Ophthalmology Society's novel collection. Thanks so much for your time and attention.
Dr. Pradeep, over to you.
I think it's been a wonderful presentation, Dan. I honestly speaking, my canvas was all blank earlier, and it has now been gold-plated by your beautiful presentation, highlighting the role of the visually VOR to differentiate such a simple thing, which could differentiate such a thing which I was honestly not aware of. So thank you, Dr. Dan. I think it was a wonderful presentation. I mean, I have honestly not seen any case of canvas. I don't know how many, because I think the prevalence is very low, or maybe we are missing it as something else. How much is the prevalence in your area, Dan?
Yeah, and thank you for that. So it's a relatively rare condition, but again, now that we have the gene, it might be much more common than we thought. So the phenotype expands, the prevalence expands as we continue to test more and more patients. So I'm not sure. I see way more of this than lots of other people. I realize that, but it's such a simple test that, again, should just be performed in anybody who has balance problems or downbeat or vestibular loss. Gives you a lot of information.
Any specific medication is being thought of for these patients? I mean, anything that we can offer apart from rehabilitation?
Yeah, a great question. And these patients are very tough because they have multiple balance systems that are affected to a significant degree. I always try dalfampridine for immunopyridine. I've never had a patient with canvas who really benefited from it. I did mention in passing SCA27B. That should be on everybody's radar. And maybe that should have been my talk instead of canvas and the VVR. SCA27B is probably the most common cause of downbeat. And we, as neuro-ophthalmologists, see a lot of patients who have downbeat that's quote unquote idiopathic. A lot of those patients might wind up having SCA27B. And those patients can be very responsive to 4-aminopyridine. That's why I mentioned that. That might even be sort of a diagnostic test.
Okay. Yeah, that's what I thought, 4-aminopyridine. Oh, thank you. Thank you then.
Absolutely.
Any other questions from any of the other panelists? Or should we go ahead to the next case then, Satya? Okay, I'll invite the next speaker, Dr. Luciano, and I'm going to introduce her. So she is a senior physician specialized in ophthalmology, in neuro-ophthalmology in Argentina. She's into private practice. She is a reviewer of neuro-ophthalmology papers of the Journal of Argentine Council of Ophthalmology, has had an international observership at Moorfields and at the Thomas Hospital, London in UK under Dr. Gordon Plant. And she's also an international fellow of the NANOS. Over to you, Dr. Luciana.
Hello, how are you? Thank you so much for such a kind introduction. I'm going to share my screen. So here I am. Well, so I will start my presentation. Follow the rule. Here you can see the rest of the authors that are also part of the team. I have no financial disclosures. So this case, it's about a 77-year-old Caucasian male who was referred for 1 month history of rhabdosis and hemicranial headache. His past medical history included metastatic prostate adenocarcinoma. He had undergone radical prostatectomy and radiotherapy. He also suffered from high blood pressure. His past ocular history was not relevant, and he was on hormone therapy, dexamethasone 4 milligrams per day, antihypertensive, and inhaled corticosteroids. So here you can see the metastatic lesions known so far when the patient was referred. We can see the osteoblastic lesions at the ribs and the third left rib and the fifth right rib, at the left iliac bone and at the dorsal and the lumbar spine. And to the right at the top, we can see these images in the liver that were interpreted as metastatic. And at the bottom, we can see the mediastinal lymphadenopathy. So the neuro-ophthalmic examination included a best corrective visual acuity on his right eye that was of 20/200. The left eye was 20/20. The color vision was not accessible in right eye and was preserved in left eye. The right pupil was not reactive with myodrasis, and the left one was reactive. He also showed an isochoria. The intraocular pressure was normal, and the fundus examination at that time was normal. The following conditions were also found. He had frontal and maxillary right hypoesthesia. He had ptosis and mild proptosis and painful ophthalmoplegia in his right eye. So here we can see the 9 cardinal position of gaze of the patient. We can see the palpebral ptosis, the full extraocular the movements with his right eye, the impossibility to perform any movement, with his right eye, and the left eye, the full extraocular movements with his left eye. So an MRI and a CT scan was performed. The CT scan showed an enlarged proximal portion of the extraocular muscles, especially the right lateral rectus. We can also see a neuro-formation of soft tissue density on the stellar tuberculum that infiltrates the cavernous sinus with right predominance, and the mucosa occupation and perimeter thickening of the sphenoid sinus. And to the right, we can see the bone destruction of the septile moidal layer cells and walls of the maxillary sinus, completely eroding the medial wall. So a sagittal T1 MRI of the brain showed a reduced caliber of the optic nerve upon entering to the orbital apex, and an axial T2 of the brain MRI scan showed the compromise of the right cavernous sinus. And at the bottom, we can see the enlargement and filling defect in right cavernous sinus, suggestive of thrombosis. So here we can see the radiographic characteristic of the lesions, the neoformation of soft tissue density, the bone resorption and the osteolysis, and the restrictive behavior in diffusion sequences, ADC. So here is the biopsy. The biopsy was performed by endoscopic rhinosinus surgery. Here we can see the hematoxylin, here the eosin, and to the right we can see the positive reaction for immunohistochemical studied for prostate acid phosphatase. So we had a case of painful ophthalmoplegia in a patient with compromise of the paranasal sinuses, the orbit, the extraocular muscles, and the cavernous sinuses, who had a prostate adenocarcinoma stage 4 as a primary tumor. So what about prostate cancer? Is the second leading cause of cancer-related death in men. The usual pattern of the spread of metastatic prostate cancer is to the bone, 84%, to the distant lymph nodes, liver, and thorax, around 10% each. And individual case studies have reported prostate metastasis to the sphenoid, maxillary, and ethmoid sinuses, and the compromise of the cavernous sinus. So bone metastases from prostate cancer are mainly osteosclerotic and caused by a relative excess of osteoblastic activity, leading to an abnormal bone formation. So they are mainly osteoblastic in nature. Here are some words about cavernous sinus thrombosis. It's a rare but potentially lethal disease. Can present with meningitis symptoms, proptosis, chemosis, pyrexia, cranial nerve deficits, papilledema, severe lethargia, and coma. And risk factors include, among others, infections, neoplasias, hormone replacement therapy, pregnancy, thrombophilic disorders, and trauma. So coming back to the patient, here we can see the correlation between the signs and the symptoms of the patient and the topographic location. So we can see an impaired visual acuity that was due to the compression of the optic nerve upon entering to the orbital apex, as we had seen before. The right frontal and maxillary hypoesthesia was due to the affection of the first and second trigeminal nerve, the ptosis and the myodrasis due to the compromise of the third nerve, the painful ophthalmoplegia caused by the third, fourth, fifth, and sixth nerve, and to the enlargement of the muscles. And also the malproptosis could be due to the enlargement of the muscles and also to the right cavernous sinus thrombosis. What about the right cavernous sinus thrombosis? It could be due to the neoplasia per se, or perhaps to the hormone therapy, because he was on enzalutamide and on dutasteride. So here you can see a timeline of the procedures that were performed to the patient from the first appointment up to the diagnosis of metastatic and resectable carcinoma of the sinonasal tract and the indication of radiotherapy. So following Dr. Lee's rule of cancer, we must say that a referred oncology patient with cancer, we should think the diagnosis as a direct effect from cancer, as a metastatic disease, or as an indirect paraneoplastic effect, or as a common or uncommon treatment side effect. So in this case, yes, the patient followed the rule. So about the topographic lesions of the patient, here we have some reports that shows that it's not so common to have the metastasis at this level. So in this case, the patient did not follow the rule. So about the nature of the bone metastasis, the ones from prostate cancer are mainly osteoblastic natured. So at this level and in this case, the patient did not follow the rule. So as a take-home message, I could say that in a patient with a cancer medical history, this etiology should be prioritized in other concomitancies, even if lesions do not have the typical location or radiographic appearance. However, differential diagnosis to be considered even in patients with advanced stage cancer in order to rule out other etiologies because they do not always follow the rule. Thank you so much.
Thank you, Dr. Luciana. Dr. Jenil, over to you.
Yeah, thank you. Thank you, Dr. Luciana. Excellent case. From the diagnosis point of view, I think multiple cranial nerves are involved, and then we need to localize. From the imaging and correlating to the clinical findings, I saw that the eye which was affected had 20/200 vision, and it was mid-dilated anisocoria, probably due to involvement of the efferent pathway of the third nerve. But do you believe the optic nerve was also involved in the right eye?
The optic nerve, yes, it was involved. It was not paled in the first examination. I think it was an early stage of compression. So then in the subsequent examinations, we noticed that the nerve start becoming a little bit paled. So yes, I think it was compromised, the optic nerve.
Also, we do have a good number of cases with where we do imaging for some other reasons where we suspect mononeuropathy or polyneuropathy. But we always come across, and I'm sure many of us from India would agree that a lot of mucosal thickening of the paranasal sinuses. And we are always afraid that are we dealing with infection because it's an incidental finding. We were trying to look at some other lesion. In your case, how did you?
He didn't have any infection. We checked that, and no, we didn't find any infections at that level. It was metastasis only.
So in the beginning, when the imaging was for the first time when you reviewed the images, you had a differential of whether the etiology could be hormonal therapy, which is responsible for cavernous sinus thrombosis, or like follow the rule you said that cancer, so it is almost always cancer.
Yes. Yes, sorry, I couldn't understand your question.
Did you think of hormonal therapy as one of the etiology for cavernous sinus thrombosis?
Yes, I think it could be both. It could be the hormone therapy, and it could be also the neoplasia. But both there are reports that shows that hormone therapy could cause the thrombosis, the cavernous sinus thrombosis.
Dr. Jenil, I'm going to interrupt you. Dr. Neil Miller, you have a comment?
Well, I had a question for Mariana. I'm sorry, Luciana. How much chemosis and proptosis did that patient have?
It was not too much. It was like a mild proptosis.
So I think it's really interesting because normally, whether it's infective or aseptic, cavernous sinus thrombosis creates a much bigger picture, a much more severe picture. And it suggests, I think to me, that this was a very slow, progressive process that had been going on a long time. So the vascularity was able to compensate to a great degree. And I thought that was a really interesting aspect of the case.
Yes, I think the same. It was not, it was mild, and yes, I think it was a long process, and that is the reason I think so.
Thank you, Dr. Luciana. Thank you, Dr. Jenel. If anybody has more questions, then we could discuss on the chat box. We'll go on to the next speaker, Dr. Dean Sistari, and I'm going to introduce him. So Dr. Dean is the professor of ophthalmology at the Harvard Medical School. He's affiliated with the Massachusetts Eye and Ear Infirmary at the Harvard Medical School, Boston. He's completed his residency in neurology as well as ophthalmology from the Cornell University. He's completed fellowship training from the Massachusetts Ear and Eye Infirmary, Harvard School. He's approximately one of the 10 physicians in the United States who's board certified by both American Board as well as the American Board of Psychiatry, Neurology, and Ophthalmology. He's involved in medical education and is the director of Neuro-Ophthalmology and Adult Strabismus Fellowship at the Massachusetts Ear and Eye Infirmary. So over to you, Dr. Dean. Over to you, Dr. Dean.
I'm just sharing. Hold on a second. Can you see can you see the screen and hear me?
Yes.
First of all, thank you very much for the invitation. Every year I look forward to this event and seeing a lot of colleagues and friends. I wanted to present what I think is an interesting case that we don't really see that often, and I wanted to hear what people think about it. So it's called The Missing Element: Unraveling the Mystery of Vision Loss. And this is a 30-year-old woman who presented with decreased vision in both eyes. And the story starts about 9 months earlier when she had a normal exam and everything was fine. And about 6 months prior to presentation, she actually experienced approximately a 50-pound weight loss over a 3-month period of time. It was associated with nausea and vomiting, and she had an acute episode of cognitive decline characterized by delirium and vision loss. And this was just for a period of 3 days. An initial workup showed a normal CAT scan. And the presumption or thought was maybe there was a thiamine deficiency and she was given it prophylactically or actually as an acute treatment. And there was some improvement in her vision and her mental status. 3 months prior to her presentation to us, it was observed that there was a slowly progressive decreased vision peripherally in both eyes. She denied eye pain or pain with eye movements or any kind of acute episodes of vision loss. She saw her optometrist, who referred her to an ophthalmologist, who then referred her to Neuro-Ophthalmology for the presumed diagnosis of an optic neuropathy bilaterally. In terms of her past medical history, she has myopic astigmatism, but importantly, she has a short gut syndrome. And as you'll recall, that's characterized by an abnormal small intestine that often results in decreased nutrient absorption. She also has diabetes mellitus, chronic kidney disease, a right-sided below-the-knee amputation, migraines without aura, and a post-traumatic stress disorder. There's a list of her medications there. She also has glaucoma and Crohn's disease. Now, when we saw her, her examination was really consistent with decreased visual acuity bilaterally to about the 20/60 level. She had diffuse dyschromatopsia bilaterally. The pupils did react and they were round, but there was no relative afferent pupillary defect, and the rest of the slit lamp examination and efferent examination were completely normal. These are her automated Humphrey visual fields. As you can see, there's decreased sensitivity bilaterally. These Dr. Rizzo and Dr. Lucelle would always say these are completely meaningless. So she wound up having a Goldmann visual fields. It was performed at Children's Hospital. And you can see there was basically a tunnel vision with sparing of about 5 degrees in both eyes. This is a fundus photo, or these are fundus photos of both eyes. And you can see on the right, there might be a little bit of temporal pallor in the right optic disc. The left appeared normal. And the macula, vessels, and things like that were completely normal. And really on her OCT scan, there was diffuse thinning of the ganglion cell layer. You can see here the average thickness on the right eye was about 51, and on the left, about 52. This was considered grossly abnormal. Now, this happened a few years ago, so based upon this presentation, she was admitted to the Mass General Hospital for further workup, including an MRI of the brain in orbits with and without contrast, and I'll show you that in a minute. She had a neurology consultation, and on her examination, they determined that she had decreased sensation, so a sensory peripheral neuropathy to light touch in the distal arms to the level of the mid forearm, and in the distal left leg to the level of the knee. And remember, she had a below knee amputation of the right leg previously. She had an inconsistent proprioceptive deficits and loss of vibration sense at the left ankle. Her MRI scan showed no enhancement of the optic nerves, but it was really interpreted as atrophy of both optic nerves, right greater than left. And you could probably see this a little bit better in the coronal T2. There just seemed to be a little bit of atrophy with an enlarged subarachnoid space here. So I don't know if this would be a good place to turn it over to the panel to see what everybody thinks about this, or I could kind of continue and then we could have a discussion afterwards.
Any of the panelists, any comments, any of the other consultants attending? Does Dr. Neil or Dr. Gordon have any comment? Okay, we'll go on, so.
Sure. So the main concern in somebody with a short gut syndrome is going to be a nutritional deficit. And she was already treated with thiamine, and her thiamine levels, I don't have them here, were completely normal, as were her vitamin B12 levels. And then remember, she presented in 2020. And so when we tracked her levels, she had initially some decreased vitamin A as well as vitamin E, but by September 2019, they had completely normalized. And remember, she's presenting in 2020. The interesting thing was that her copper and zinc levels were on the low side during her presentation. And you can see it's mapped out really well here. So her copper levels back in 2013 and 2014 were normal. They decreased down to 2016, and then they normalized. Okay, this red line represents the normal levels. And really, when she reached over here in the summer of 2020, spring is really when the copper levels went down. And this is when she started to notice decreased vision. Okay. And then she was supplemented. So we really thought that this was a nutritional optic neuropathy, likely associated with decreased copper and or zinc levels. She deferred her lumbar puncture, so we weren't able to actually analyze the fluid, and she was actually given parenteral nutrition to include vitamins that we thought were going to be implicated in her nutritional optic neuropathy. About 3 months later, she was readmitted to the GI service for anorexia for about a month. She was found to have a UTI. She refused NG tubes, but she was started again on TPN. And again, her exams stabilized, but never improved past this 2050, 2060 level. So our conclusion was that this was a nutritional optic neuropathy, in part secondary to deficient copper and/or zinc. And again, there's not a great literature on this. This was a nice paper by Stacy Pinellas, Steve Galetta, and Laura Balser. This is a very rare condition that you can get a bilateral optic neuropathy and myelopathy in copper deficiency. And it's thought to inhibit oxidative phosphorylation and affects the mitochondria. And that's thought to be the basis of the bilateral vision loss. And sometimes the vision is reversible, but in our case, it really seemed to stabilize, but not improve. So it's a rare entity, and it's always in our differential diagnosis for patients who have a history of some kind of gastrointestinal disease and unexplained optic neuropathy. So I thought it'd be an interesting case, and would love to hear what people think about it.
Thank you, Dr. Dean, for sharing this interesting case. Actually, I think nutritional optic neuropathies might be on the rise because a large number of patients are on, strictly vegan diets or, 1 meal a day diets and very heavily into intermittent fasting and all of that. So I'm glad that you highlighted this case. You mentioned that, that the patient deferred an LP, but what was the indication of doing the LP in this case?
Well, I think anytime somebody has an unexplained optic neuropathy that is progressing, our teaching is that you should do an LP just to make sure that the CSF fluid is normal, that you're not missing some kind of occult infection or some other explanation. I would like to make a comment, if I can, about what you had just said in terms of nutritional optic neuropathies. Certainly in the United States, obesity is on the rise, and it's a huge problem. And many people are undergoing these gastric bypass procedures. But the GLP-1 inhibitors like Ozempic are becoming the most prescribed medication in the United States. It's probably going to become amongst the most successful drug in history. And our group just reported a possible association of ischemic optic neuropathy in patients taking that medication. So it's going to be interesting to see if we see a shift in patients in terms of treatments, and to see if we get a rise of ischemic optic neuropathy or not.
Yeah, but Dr. Dean, was there in that paper, it was said that it was not really the drug Ozempic which caused the ischemic optic neuropathy, but the rate at which the glycemia control was achieved. And maybe that is a bigger risk factor for ischemic optic neuropathy.
Right. So
we don't.
That's right. So we definitely did not conclude that it was the drug itself, and possibly it was the patient population. Remember, the people who are on that type of drug tend to have the worst obesity and diabetes and things like that. And we know that poorly controlled diabetes is a risk factor, or thought to be a risk factor for NION. So we don't know if it was just the patient population and their glycemic control that was the main risk factor, or the medication itself. You're absolutely right.
Dr. Dean, there's one question. When you suspect patients are having nutritional optic neuropathy, you usually do a fixed set of tests. So would you always include zinc and copper levels as part of your workup?
Certainly it depends, right? I mean, thiamine deficiency in general does not cause an optic neuropathy, right? It's an ataxia and an ophthalmoparesis. You can have like an nystagmus, and you can have an ataxia. You don't always have that triad, as we know. I think we tend to just order a lot of tests to make sure we're not missing something. So usually if we suspect that there's a nutritional neuropathy, we will do a bucket of like B12, thiamine. I tend now to do copper and zinc because we've seen a few more of these patients and been surprised, and it gets missed.
What
You
about
could argue,
MMN
though,
folate?
well, you can, but folate doesn't cause an optic neuropathy. I mean, everyone always orders it, right? But it's the thiamine deficiency, not the folate. Dr. Lassell used to really emphasize that. And you could argue, is the treatment going to change? Because you can give a multivitamin, right? If you suspect a thiamine deficiency, you have to urgently give that IV. So sometimes you'll do that before you'll even get the results. But we tend to test for all of the pertinent vitamins. We've seen occasionally a vitamin A deficiency. It's rare. It tends to cause other types of things in terms of like corneal melts and the retinopathies, but I think rarely can actually cause a optic neuropathy also. I'd love to hear Neil's thoughts on this.
Dr. Neil Miller, you have a comment?
Well, I have to respectfully disagree with Dean.
Okay.
I do think that folate deficiency is a major potential cause in patients with alcohol-related or nutritional disease. I think the reason that it gets a bad rap in terms of its involvement with the etiology is that most people assess folate levels in the serum, and the serum is not a good indicator. If you're going to check folate, red blood cell folate is the way to go. And I think Carl Goldnick and others have shown, to my satisfaction, that folate can be a major issue. And we've treated a number of patients just with folate. Of course, you tell them that it's nutritional and you're going to prescribe folate, and heaven knows what other medications they take. But I do think that it's worthwhile testing red blood cell folate in anybody in whom you suspect a nutritional deficiency. The other thing I think is fascinating in that list that you showed, Dean, is you would expect, or I would have expected, multiple vitamin deficiencies.
Right.
And yet in this particular condition with copper deficiency, and as Uma said, it's the zinc that's in a sense the problem. It's fascinating to me that you don't see like multiple ones like the prisoners in World War II, et cetera, who had the peripheral neuropathies and the whole bit.
Right. No, I totally agree. I mean, right, so D, E, A, and K have to do with like fat malabsorption more than regular malabsorption, and the short gut syndrome. I'm not exactly sure why. Maybe some vitamins are deficient than others, but I agree with you. But that's why I think, yeah, we check everything and we tend to then treat with a multivitamin. Certainly if we suspect or know that it's exactly B12 or thiamine deficiency, we'll give that either IM or IV. It's interesting to hear you say that, Neil, about folate, because I just wasn't aware of it. And really, Simmons used to teach that
I know.
folate was not the cause of it, but I guess
Simmons and I had a lot of discussions about that.
Really?
By the way, it's also worthwhile just keeping other things in mind. I have when you suspect a nutritional issue, I had a patient, a young woman, who had a gastric bypass for obesity, and she got very ill and lost vision in both eyes and had supplementation, and she actually was suing her surgeon and came to us. And to make a long story short, she had demyelinating disease. She had MS.
Right. That's such a really good point, because I think any of these cases, and you have to check for NMO, you have to make sure that there's not another explanation for the vision loss. You can't just say, oh, there's a short gut syndrome or they had gastric bypass, it must be a vitamin deficiency, right? We know patients can have more than one disease. So that would be part of the workup in any kind of nutritional deficiency. Certainly aquaporin 4, make sure that this isn't NMO or another type of multiple sclerosis or something like that that's mimicking it. Usually there'd be some kind of enhancement of the optic nerve or some other symptoms, but certainly I agree to send testing. We even sent, I think, in this case, but I didn't put it in here, genetic testing looking for, Leber's hereditary optic neuropathy and things like that. but you know, when common things being common and short gut syndrome, with the vitamin levels low, I think that this is related to copper and or zinc. So Neil, do you think this is more copper or more zinc? I think that's a debate too.
Well, I think
doesn't matter.
Yeah, I mean, I've always thought that it was the zinc effect on the copper that was the problem.
Right. You have to supplement both.
Also, Dr. Dean, your patient additionally had diabetes and had, kidney failure. So you think there was a combined mechanism of ischemic along with the nutritional all working together?
You mean in terms of like an ischemic optic neuropathy?
Yeah.
I don't know. Most of the time, it's certainly not Nion because there was no disc swelling, right? There was no anterior component to it. And there didn't seem to be, well, I guess there was subtle optic atrophy and the ganglion cell layer was atrophic. I think it's hard to know. I think primarily it's related to the nutritional deficiency, but you're right, there's multiple risk factors, so it's hard to know. Absolutely.
Dr. Pradeep, do you have any comments? Dr. Pradeep Sharma, sir?
No, I would think that unlikely to be ischemic because the presentation, the visual fields are sparing the central area, which is more typically seen with the toxic or the nutritional deficiencies.
Okay.
That's a good point, yes.
Okay. Thank you, Dr. Dean. We'll move on to the next case.
Thank you, everyone.
Thank you.
So I'm going to introduce my last speaker, Dr. Edsel. He works in the Department of Ophthalmology and Vision Sciences at the University of Alberta. He has several publications, 155 works on ORCID, 3 fellowships from Mayo, Bills, and Allegheny General Hospital, has done his master's in public health, has done his master's in international affairs and diplomacy, and was also a PhD from Kingston University. His thesis topic was GCA. He's a Master of Education at Johns Hopkins and an MBA from Louisiana. So over to you, Dr. Edsel.
Well, thank you. Thank you so much, Hemalini. Embarrassing part is I'm going to have troubles just trying to get my slides on. So do you see anything there?
No. Yeah.
Oh,
yes, we do.
Okay. Great. Great. So greetings from Edmonton, Alberta, and thank you, Dr. Satya, Dr. Hemalini, and Dr. Preeti for organizing this wonderful conference. And I'm learning a lot, especially from the first case, the state of liminality that I've been in for the last 30 years since the honeymoon.
The presentation, you might have to check. We are getting the notes.
So what we can see right now, Dr.
I think I can switch the screens. Yeah, let me see if I can try to switch the screen. Sorry about that. Good one. Well, worst comes to worst, I can try to enlarge this. Yeah, I'm not sure how to switch the screens. Yeah, apologize. Does anybody know which thing to flip here?
I would say you need to get out of the presenters mode.
Sunilji, can you help?
Yeah. Hello, doctor?
Yes, hello?
Yeah,
So
but you need to exit from the presenters mode. You're in presenters mode.
Oh, exit. Okay. Yeah,
Hello?
it's just your
hello.
Yeah. It's just all your icons are blocking all the Zoom icons are blocking.
Can you stop share for a minute, doctor?
Sure. I'm trying to look for your Zoom screen here.
I've stopped it. Just click on the share screen button once. That's it.
Okay.
Don't share. Just click on the button once. Bottom there will be an option called Optimize for Windows. Just uncheck that.
Optimize for Windows.
When you click on the share screen button once, you have 2 options: share sound. The other one is Optimize for videos. Just uncheck the Optimize one.
I see optimized for video clip. I don't see any other
Optimized for videos,
optimized.
just please uncheck. It should not be checked. Just uncheck.
Oh, okay. I'm happy to do it. I just don't see the optimized thing you're asking me to uncheck.
Is it checked or is it unchecked, sir?
I only see optimized for video clip, nothing checked. I see share sound, nothing checked.
Okay, shares. If the share sound is okay, rest is unchecked. You can start sharing again. Only share
Okay.
sound should be checked.
Oh, I didn't check share sound.
Just check share sound. The other box should be empty.
Okay. And
How you can share,
optimized for
please?
video clip is also empty?
Yes, that will remain empty.
Okay. And then I can click the blue share now?
Yes, sir.
Is anything different this time?
You can. We are actually seeing the presenter's view. You need to know that again the ghost thing is again coming.
Okay, let me try to get it out of presenter view then, if it's possible.
It looks like the laptop setting rather than the Zoom window again. It is on. Or you can try doing checking that for once. Just check that box once. Let's see if it
Okay.
does any different.
Yeah, thank you so much for your help. I don't understand what you want me to do.
Edsel, do you want me to
Can
do
you?
the presentation from my side?
Sure. Oh, okay. There's some of the other cases. There's some more summary slides. Let me take it out of presenter view. Maybe I can do that.
So,
sir, आप share कर दो ज़्यादा वो रहेगा.
yeah, but he has some more slides. So,
Okay.
shall we give you a few
Sir,
minutes? We'll go to the next speaker.
Oh, sure. How would I set it up? Because like it works fine on my side. How do I know if it's going to work on your side?
Sir, your video is also in presenter's mode. You need to exit from the presenter mode.
I did. So I can try again.
And this time, just check the box once. So just check both the boxes. Let's see if it does any different. Share computer sound and optimize all and optimize things. Sorry.
So this time, put a check mark in both of them, huh?
Yes.
Okay.
Because without checking, also it is giving the same error.
Oh.
Now we can see your desktop.
Sorry.
We can see your desktop now.
Yeah.
You can open the presentation and then do the screen share.
What do you get this time?
It's still the same.
Oh, but do you see anything?
So I think it's a laptop issue rather than a Zoom issue.
Well, I think I just have one suggestion. Can we click on the icon that says start the PowerPoint show at the bottom?
Doctor, there are ghost boxes on the PPT on the sharing.
No, they will be visible. You just go and put it now in slideshow mode. I think
Exactly. So if we can just start that slideshow mode from the icon at the bottom.
Yeah.
Does this do anything?
You got it now. You got it.
This is good.
Okay, great. I'll just keep it out of presenter mode. I'm really sorry about that. So thanks for the opportunity to present this talk on Nutamen oculi. And I'm learning a lot during this conference, especially from the first talk. I know what the state of liminality is. It's been what I've been going through since the honeymoon. So all kidding aside, this is a 65-year-old patient that was referred for a supposed carotid cavernous fistula. He had a 1.5-month history of painless, constant left eye movement, which was worse on exertion. There was no history of trauma. He was not hypertensive. He did not have a subjective bruit. There was some facial asymmetry, as you see there, but no history of dysthyroidism. Past medical history was non-contributory. He had urticaria, for which he was taking Xolair and a bit of reflux. On examination, acuity was 20/25 in both eyes. There was no relative afferent pupillary defect. Confrontation fields were intact. Intraocular pressure on tonopen was 13. The conjunctiva was white and quiet. motility was full, and there were no iris nodules. On fundus exam, there was no retinal venous engorgement, no disc edema, and no cup disc asymmetry. So hopefully the video will run. And this is what the patient looked like when we saw him. And you notice his anterior segment is completely white. Just in case you couldn't see it on your computers there, this may show it a little bit more dramatically. You notice his deep superior sulcus, wider vertical fissure. There was no history of dysthyroidism. He just has a little papilloma on his lower eyelid there, inferocentral. So
yes.
This is not the same patient, but the patient had the same problem in 2012, and I happened to be doing the OCT. I thought this was sort of neat.
Yes.
If I don't let the presentation run, it'll stop. So.
Yeah, just take maybe 10 seconds.
So Nutamen in Latin means bobbing, and I thought it was appropriate to label the talk as such, giving the bobbing B scan and the bobbing eye. Here's the patient's MRI, and you see there's an orbital roof defect with the meningocele and herniation of fluid into the left orbit. Things are seen much better on CT scan. Here, if you start on the top left and proceed, you can see this meningocele here, and on the bottom slides, this island bony defect there. On sagittal scan, you see this angulated bone fragment. Okay. So to summarize the case, a 65-year-old gentleman with recent onset pulsatile proptosis, but no episcleral venous congestion, no head trauma that he could recall over the last 55 years, on imaging, orbital roof fracture, and a meningocele. So just asking the patient again and again about any past trauma, he said, well, oh yeah, at age 10, this girl hit me in the eye socket, and I went unconscious for a while. He does not recall if there was much bruising there, but I guess in children who get white-eyed blowout fractures of the inferior floor, you may not see a lot of findings, and perhaps that's not so remarkable that he didn't recall a lot of bruising in the area also. So a patient was sent to neurosurgery, and instead of doing a bicoronal flap, they were able to repair this through a brow approach. They used porous polyethylene and a pericranium flap. On the MRI on the right there, you see his repaired orbit. It looks pretty good. So all of us are familiar with the cardiac periodicity that gives you brain pulsations. Here is a 3D amplified MRI showing the pulsations of the brain. Now, these are exaggerated probably 17 to 25 times. Normally, the biggest excursion would be, I think, about 0.8 millimeters, and the pulsations are more in the central part of the brain than in the periphery. There is nothing fascinating to pulsating exophthalmos. And even in 1916, Rhodes described over 309 cases of pulsatile proptosis. However, it still merits reviewing the differential diagnosis of pulsatile proptosis. We mentioned our orbital roof fracture or post-neurosurgical procedures where they're doing subfrontal approaches, meningoencephalocele, arachnoid cysts, and a common board question for pulsatile proptosis is neurofibromatosis type 1 was sphenoid wing dysplasia. If you have a bruit, you might suspect more carotid cavernous fistula or AVMs or varices. You can also have ophthalmic artery aneurysms and pseudoaneurysms. And there's also some cases of induced dynamic proptosis. If you have a very large tumor or say something like a mucocele there, you can induce the proptosis with just a little pulsatile proptosis with a bit of pressure. If you see bilateral globe pulsations, just keep in the back of your mind if it's not something related to a carotid cavernous fistula, aortic regurgitation. So in this, your normal pulse pressure is about 40, and you see on the right, this gentleman's pulse pressure was 100, and they had pulsatile proptosis from it. Now, what other things are dynamic proptosis, but not pulsatile proptosis, so to speak? All of you have seen cases of Valsalva-induced proptosis or exercise-induced proptosis. Just as an aside, if you want to get the Guinness Book of World Records, Valsalva-induced proptosis record, you have to bulge your eyes 17.2 millimeters. And you're also used to cases of globe luxation where the eye doesn't go back unless you digitally push it back. Patients with floppy eyelid syndrome, Graves' disease might have this eye popping phenomenon. So take-home points for this case, remote trauma, in this case 5 decades earlier, can cause neuro-ophthalmic signs. Orbital roof fractures can be repaired without bicoronal flaps. When you're looking at pulsatile proptosis, if there's no episcleral injection, it's very hard to imagine it's going to be from a carotid cavernous fistula. I don't think that a posterior draining carotid cavernous fistula would cause proptosis. Looking at the direction of the globe displacement will help localize the pathology. If you noted on the videos, the direction of the pulsatile proptosis was inferiorly and anteriorly. And so this would tell you that the lesion would probably be in the orbital roof. If you see bilateral globe pulsations, remember, in addition to carotid cavernous fistula, you could have aortic regurgitation. And things that the patients or referring doctor might be describing to you on the phone that aren't pulsatile proptosis include your Valsalva retinopathies or eye-popping phenomena. Now, in some very busy comprehensive practices, they no longer use the Goldman tonometer, and you might miss the pulsatile Myers. In many practices, they just use the tonal pen. The other thing, too, is many clinicians, comprehensive ophthalmologists, may not be actually examining the patient's fundus anymore. They do photography, just look at the films and don't examine the patient's eyes. So I presume that bounding B-scan OCT sign would pick things up like pulsatile proptosis quite early. So if you happen to have one of those practices where you don't have enough time to actually lay hands on the patient, you should teach your techs to come get you if you see that bounding B-scan. So I hope that all of you enjoyed the presentation. Technically, I think you're all Rhodes Scholars now, and I hope many people will be coming to get your eye heartthrob expertise in the future. Thank you.
Thank you, Dr. Etzel, and Dr. Preeti, over to you for discussion.
Yeah, thank you,
I'll try
Dr.
to.
Yeah.
Yeah, I'll try to stop sharing screen. Not sure where all the buttons disappeared to. Okay, so if I push stop share, okay.
Yeah, I think we've stopped. Thank you so much. That was really an interesting case. So I think we have one question in the chat box already. Dr. Miller was asking if there was any oscillopsia, especially while chewing, or any enophthalmos that you noticed.
Okay, with regards to enophthalmos, there was none even when he was lying supine. The left eye was more proptotic. I didn't ask him about oscillopsia with chewing. He didn't complain about the oscillopsia when he was looking straight ahead, which was quite surprising to me. So Neil, do things get a lot worse when the patients chew?
Well, it all depends. The reason I was thinking of it, first of all, it's always fascinated me, now that we have 3D printing, when we have patients who undergo neurosurgical procedures, they usually replace the bone if we take the orbital roof off. But in the older days, we just put some gel foam there, and invariably there were ocular pulsations. But interestingly, at the beginning, the patients would notice some degree of oscillopsia, but within a few weeks or months, they somehow adapt to it, so it doesn't bother them. There was actually a fascinating case, and it was just something as you pointed out at the very beginning, the patient didn't have any Lish nodules, but there was a great case presented at the Walsh meeting probably 15, 20 years ago of a police officer who developed a traumatic carotid cavernous fistula and had pulsating enophthalmos. And the reason she had enophthalmos was that she had NF1. So she had the sphenoid wing dysplasia or absence of the sphenoid wing on that side, and then developed a fistula. So she had the pulsations, but it was enophthalmic. The issue about chewing oscillopsia, not for this case, but as you started to report it, I wondered if the lateral wall was off. In some patients who have dermoids or something that eats away the lateral, especially posterior wall of the orbit, you can get chewing oscillopsia because the temporalis is right adjacent to the periorbita. So whenever the patient chews, he or she develops oscillopsia. So I was just interested in that possibility. Great case.
That's super. Yeah, they also have a chewing gum called eye poppers that I was wondering if you're going to tell me about that, like British chewing gum called eye poppers.
Dr. Walsh used to have a patient who could sublux the eye outward, and he would show it at a Saturday morning conference every so often. Dr. Sharma knows about that case. These people who can sublux the eye are scary because the eye comes out and you think, oh my God, what's going to happen? And they just know to put it back, or it goes back spontaneously.
Yeah, another thought I had was this was so many decades after the initial trauma. Do we see that often, or would you expect like a secondary trauma or something to now make it symptomatic when it's been quiet for 4 or 5 decades?
Yeah, that's an excellent question, Preeti. So I took some poetic license for this talk. I think he had an ear problem and had a scan done like maybe 10 years before. And they also saw the defect back then. And they didn't say it got that much bigger. So I'm not sure what tips things over that, just 1.5 months before his presentation, he started noticing things. He does not sleep prone. I asked him that. But a very good question, which I don't have an answer to. But between Miller and Plant, I'm sure we will come to a solution.
Any thoughts on that, Dr. Miller, or anybody else in the panel, as to why are there any things that we should look for or ask for that could make these cases that have stayed quiet for so long symptomatic?
Oh, it's fascinating. I agree. A lot of it obviously was there. Maybe there was some spontaneous degeneration of the bone over time. I mean, with the pulsations, it can wear away the bone. And so I suppose it's possible that there was an increasing area of encephalocele, or at least lack of any bone between the dura of the frontal lobe and the superior periorbita, something like that.
Dr. Pradeep Sharma, you have any comment, or any of the other panelists? Any comments?
No, nothing specific. I think it was an interesting case, definitely.
Okay. Did he have any headaches?
He was painless for him. It was just the movement.
Okay, and how was his blood pressure?
Oh, his I don't have the number, but we did check that. I would expect it to be worse if it was both eyes. the proptosis, the pulsatility increased in frequency, as you might suspect, with exertion, but his blood pressure in the emergency room was normal.
Yeah. Dr. Exel, there's a question from the audience that could there be an associated raised CSF pressure which led to more encephalocele?
I think that's something that's very astute. He didn't have floppy eyelids. I did not ask him specifically about the sleep apnea. I didn't do that stop bang criteria. But if he ever comes back, I'll make sure we ask him that question. Thanks for proposing it.
Dr. Preeti, anything else?
Oh, that's it. I think I'm just looking. I don't think we have any other questions either. There's a comment which says that the other differentials could include orbital varices or absence of the sphenoid wing. I think we've discussed that already.
Okay, so with that, I think we'll wind up with this second interesting session with fantastic speakers and look forward to the next session. So over to you, Dr. Satya.
Thank you, Himalini. And I would like to now introduce the moderator for the third session of the day. And that is Dr. Virendra Sachdev, who is a head and consultant pediatric ophthalmology, strabismus, and neuro-ophthalmology, and head of the neuro-ophthalmology services of the LVPI network. He is affiliated to LVPI at Visakhapatnam in India. And his areas of interest are neuro-ophthalmology, optic neuritis, neuroimaging, IIH, CSVT, myasthenia, and complex strabismus. He has more than 90 publications and 16 book chapters. He's been the principal investigator for clinical trials in neuro-ophthalmology and some in-house trials in India. And he is on the editorial board of BMJ, Open Ophthalmology, Current Eye Research, and Frontiers in Ophthalmology, apart from Indian Journal of Ophthalmology. He has been an organizer for Looking Beyond the Eye, which is a meeting of eye and systemic disease. Over to you, Virendra.
Thanks, Dr. Satya, for the kind introduction. I think it has been very fascinating with all the lovely talks. So I'll have the privilege of introducing the panelists and the speakers for this session, as well as moderating the session. Let me just share the slides for benefit of everyone. Yeah. I think the slides are visible in the slideshow mode.
Yes.
Thank you. So we have a esteemed panel. Our first panelist is Dr. Ramesh Kekunaya. He is the Network Director of Technology Innovation at our LV Prasad Eye Institute, and he's also the Director of the Child Sight Institute. He looks after the Child Sight Institute services across our network. He's currently working primarily at our Hyderabad campus. His key areas of interest include complex strabismus in adults and children, pediatric cataracts, vision development, myopia, amblyopia, and pediatric neuro-ophthalmology. He has over 150 publications in peer-reviewed journals, as well as 25 book chapters. He is on the editorial board of British Journal of Ophthalmology, Current Eye Research, and BMJ Open Ophthalmology. He has been invited globally as a keynote speaker for various conferences, especially the WSPOs, where he is one of the key organizers. Our next panelist is Dr. Varshini Shankar. She is a consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology at Shroff Eye Center, and she is also director of Viva Vision in New Delhi. Her areas of special interest are disorders of convergence and accommodation and complex strabismus. She takes a lot of interest in patients with unexplained vision loss. Our third panelist today is Dr. Vinda Shah. She is the head of neuro-ophthalmology department at Arvind Eye Hospital, Coimbatore, for the last 10 years. She has over 20 years of experience in the field. She has been treating patients with adult neuro-ophthalmologic diseases, and she has over 30 publications in the peer-reviewed journals. She is also on the editorial board of many journals such as International Ophthalmology, BMC Neurology, Journal of Neuro-Oncology, BMJ Case Reports, and International Journal of Ophthalmic Plastic and Reconstructive Surgery. Our next panelist is Dr. Vivek Warkad. He is the head of the Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology Services at the Bhubaneswar campus of LV Prasad Eye Institute. He did his fellowship training at LVPI Hyderabad, followed by a training at Boston Children's Hospital in complex strabismus. His focus areas are complex strabismus, pediatric neuro-ophthalmology, and pediatric cataract. He has over 30 peer-reviewed publications, and he's on the editorial board of International Journal of Ophthalmology. Our next panelist is Dr. Jyoti Matalia. She heads the Pediatric Ophthalmology, Strabismus, and Neuro-Ophthalmology at Narayana Netralia in Bangalore, India. She has delivered over 350 lectures and invited talks at various conferences in India and abroad. She has 70 publications in peer-reviewed journals, and she has contributed to 15 book chapters. She is known for her award-winning videos and has 16 awards to her credit. She also runs the fellowship in the pediatric and neuro-ophthalmology subspecialties and has trained 40 fellows till date. Her primary areas of interest include pediatric cataract, neuro-ophthalmology as a whole, myopia management, and teaching is her passion. Our last panelist today is Dr. Rebecca Dhiman. She is an associate professor in the Strabismus and Neuro-Ophthalmology Services at RP Center at AIMS, India. She has more than 100 peer-reviewed publications. She has contributed to several books and book chapters. She is the associate editor for Frontiers in Ophthalmology in the Pediatric Ophthalmology and Strabismus section, and she is also in the Strabismus. She is also on the editorial board of IJO, Indian Journal of Ophthalmology, for the Strabismus and Neuro-Ophthalmology section. I would now introduce to you all the first speaker for today, Dr. Heidi Martinez. She is the founder of Neuro-Ophthalmology Services at Hospital San Martin in University of Buenos Aires. She was heading it until July 2021. She is also a professor of superior course of Neuro-Ophthalmology at the University of Buenos Aires. She is author of several articles. She has presented work and posters at many national and international congresses, and she is author of chapters of neuro-ophthalmology in various books in ophthalmology and endocrinology. She has also been author and coordinator for a book of distance master's degree of Argentine Council of Ophthalmology in its last 3 editions. So with this, I invite Dr. Martinez to begin with the first case. I'll stop sharing here. You can share your slides, Dr. Martinez.
Yes. Just a minute. You can see it now?
Not yet.
I'm sharing. Once and again. My camera video is going in and out.
Yeah, I think it's coming. Yeah.
Yes.
We can see. You can put in a slideshow mode.
Well, now we are.
Yes.
Thank you for the invitation and for sharing these wonderful cases. And I want to show one that I call Better Not Stick Your Nose. To patient, really. This is a man who was referred to us by another ophthalmologist 2 weeks after the onset of severe visual loss right eye associated with ocular pain and diplopia. The referral note stated that his visual acuity was 0.3 and has been treated previously with amoxicillin and clavulanate and also intramuscular dexamethasone. He has a history of recurrent sinusitis and a 20-year history of cocaine consumption. Here in the images, you can see the saddle nose that is typical of cocaine consumption, but also can appear in, for example, granulomatous polyangiitis. So, sorry, okay. We order an CT where you can see the extent bone destruction with absence of palate and nasal bones, the compromise of the inner wall of the orbit and also of the floor, a soft tissue mass arising from the nasal cavity into the right orbit, and also the optic nerve enlargement, and the sinusitis compromised ethmoidal and sphenoidal sinuses. When we received the patient, the vision had improved to 0.7 and persistent dyschromatopsia and pupillary defect, and you can see a mild defect in the fundus, but also we can observe restriction of elevation and abduction. We continue the treatment with the antibiotics, but changes to intravenous methylprednisolone and also made a consultation with otorrino. In 2 days, vision had improved, had fully recovered, but 3 days after, dropped to count finger. And you can see the visual field was not registrable and a mild defect in the right eye. In this, at this time, we consider that this can be perineuritis by contiguity because of the sinus compromise, and we order a biopsy. We must order a biopsy always to rule out other possible etiologies, mainly lymphoma, polyangiitis granulomatosa, and also bacterial and fungal infection, mainly considering that he had received corticosteroid and that the immunity in the nasal cavity fall down with cocaine abuse. You can see the improvement of the OCT before and after treatment, and also the improvement in visual field. This is the second case referred for trabeculectomy. Glaucoma had been diagnosed 5 years ago. He was actually treated with 3 drugs, and he was referred because they attribute the progressive vision loss in the right eye in the last months to glaucoma. He had an optic atrophy in the left eye that was not recent. We don't know the time of evolution. Vision was 0.3, right, left eye count finger, but you can see that the intraocular pressure was very well regulated in very good range. He has also a history of being addicted to cocaine, but he said that he had completely quit the consumption a couple of years ago. We order, of course, an image where you can see similar as the other case with extent bone destruction, pansinusopathy, and also an hyperintensity in the right optic nerve. We started with intravenous methylprednisolone, but psychomotor excitement and visual oscillation forces us to change to oral treatment. The vision improved, of course, only in the right eye, and the intraocular pressure continues to be well regulated. A remarkable fact in this patient that Bianca was positive, but all the systemic evaluation was negative with no sign of vasculitis. Of course, again, a biopsy with chronic and unspecific inflammation was found, as in the first case. So what happened with cocaine and the nasal situation? Cocaine induces a chemical sinusopathy that's going to destroy all submucal and mucosal tissue, damage the immunity of the nasal cavity, and causes a progressive necrosis of all bone of mid-face. So it can affect palate, nasal, and causes a communication between nasal cavity and the orbit, and also a nasal fistula. And the loss of immunization leads to complication, mainly infection. You can have sinusitis, epistaxis, superiosis, access, and of course, optic neuritis and orbital tumor. And what do we think about the optic neuritis related with cocaine? Of course, we can think about contiguity that is well proven because all sinus are compromised, and keeping in mind that the sphenoid sinus is very contiguity to the optic channel, and that sometimes the wall bone wall is not complete. We can attribute also to orbital inflammation, and that soft tissue mass invading the orbit can cause compression or infiltrate the optic nerve. But also we can think in ischemia, because the vasoconstriction induced by cocaine can produce this. And this is an article that showed the intensity of posterior ischemic optic neuropathy attributed to cocaine abuse. Regarding the differential diagnosis, of course, we must think in all mid-phase destruction pathologies, especially granulomatosis with polyangiitis, lymphoma, infection, idiopathic inflammation, and all kinds of pathologies. So the images show us the extension of the lesions, but are not good for the etiology. We must always perform a biopsy and sometimes repeat the biopsy. But I want to take your attention to such a kind of inverse differential diagnosis. When you are dealing with these pathologies that affect mid-phase, you must ask about drug consumption, something that we don't do usually. And this is a case related with cocaine consumption, but really was masquerading an ECG4 compromise of the orbit. And how about the cocaine? Cocaine sniffing arrived to the central nervous system in 30 seconds and reach maximum effect in 3 to 5 minutes. It blockades many substances, mainly serotonin, noradrenaline, inducing vasoconstriction, dopamine, that is responsible of the rush effect, and of course of the addiction to cocaine. But also it acts in all the system. It induces hypertension and alters hematologic parameters, so it can produce ischemic and hemorrhagic stroke, and also vasculitis, mainly by the contaminants that are present in the cat cocaine. But there is another substance that is more destructive to the brain, that is the PACO, is a cocaine residue with kerosene and sulfuric acid, whose effect of euphoria, acting like zombie and anguish, lasts only 2 to 5 minutes. So people consuming PACO uses to consume 20 to 25 doses per day. And it causes a severe cerebral deterioration in synapses. So I want to take your attention to this probability. And of course, the conclusion is easy. Better don't stick your nose. And I open to your question and comments. Maybe I can no. My appearance is not stable.
Thank you, Dr. Martinez, for a very, very interesting case. We generally use cocaine for diagnostic test of pupillary disorder or constriction, but in this case, you are showing very, very unusual, probably a sequelae of using it for a very long term. I just had one question for you before we really open it up for everyone to ask questions. Cocaine is usually osteolytic, right? It destroys the bone, especially the medial wall and probably inferior wall. And it keeps on creating this chronic sinusitis. So do you know, some of the cases it can even cause ocular motility disorders. So does the optic now comes first or the muscle comes first? You would have seen in this part of the world, I've never seen any of this complication I'm seeing for the first time. So have you seen any strabismus complication as well because of this osteolytic effect of this cocaine?
Something striking with this is that cocaine abuse is increasing. So I believe that we must see this more frequently. In literature, the reports are not so frequent. In an article in Journal of Neuro-Ophthalmology in 2014, they presented 2 cases and related about the review of the literature, where only were 6 cases before. and I made my own review and only find 2 or 3 more cases. And there are reports of exophthalmos and of diplopia, but they are also not so frequent. You can find this patient also was compromised of the motility. So I believe that in ENT literature there are more reports, but not so much. And it's again striking because they say that they are increasing reparative surgery because of the mid-phase necrosis. So it's strange. Maybe we don't report, as Miller said before. Myself, I haven't reported these 2 cases. I complain.
Okay, I think already Dr. Goldberg group I was seeing, they had 3 cases of orbital as well as optic neuropathy involvement. I just saw Dr. Bhatt putting a reference there. This is also a kind of, I think, reported PAIO, posterior ischemic optic neuropathy in the setting of cocaine-induced orbital and sinus infection. So that's also possible. And as you showed in a slide that in the last 13 years, almost 400% increase in the cocaine abuse. That's really a lot of. But in spite of that, the number of these kind of very specific complications are very rare, fortunately. Any other complication? Any other questions? I don't know whether it is a complete optic neuropathy or it's a contiguous inflammation from the sinus to optic nerve, or unless you do the MRI with the diffusion restriction, we'll not even know whether it is a hyperintensity or it's a PI1. So I think in all these cases, an MRI and other investigations are a must. Any other questions or suggestions from the panelists?
I want to make a comment. The pathological findings are not typical. They are useful to discharge other pathologies. You don't find necrotizing granulomas or the lymphomas or fungal infection, but you don't have really typical pathologic anatomy. You must see alternating area for fibrosis and ischemia, sick wall vessel in the fibrosis tissue, mainly mimicking a fibrous tumor, alternating with new insults to the tissues with ischemia and necrosis, but there is not a typical finding. So many times you must repeat the biopsy.
All right. Any other quick comments from anybody else?
Yeah, I think when we looked at our case, for instance, that we published and what you saw in the pathology, you saw the crystals, you saw the cocaine crystals, and then you saw this extensive inflammation and fibrosis around this, right? So these crystals produce inflammation and then fibrosis if it's chronic. And so, you know, there's multiple mechanisms how you can involve the orbit and possibly cause an optic neuropathy. One is a compartment syndrome from the tightness of this inflammation in the orbit. There could be a vasculitis sometimes that is caused secondary to cocaine. So CNS vasculitis, for instance, is described. You know, you can have a secondary infection from all the damage to the mucosa. Just the act of cocaine use can induce vasospasm, and maybe the posterior optic nerve is particularly vulnerable to hypoperfusion, right? So, or the contiguous inflammation extending, it becomes a very complicated problem. What exactly is causing it? But it's an academic problem because ultimately the cocaine is the reason.
Yeah, absolutely.
Yes,
Thank you. Yeah.
In the treatment of this. Sorry, in the treatment of this pathology, the most hard thing is to stop consumption because this is an addiction. And of course, if you can treat it with good or bad results, I don't have long-term results in these 2 patients because they came from distant location and they were reticent to attribute the visual travel to cocaine. but they have the thing to stop the consumption, because you know, if the cocaine continues acting, it will worse, undoubtedly.
Yeah, I was just trying to add, like apart from the involvement of optic nerve, the cocaine toxicity can manifest as, the posterior midbrain syndrome, or, the thalamic impacts, though that they do present as, the classic Kollner sign or Upgate's palsy. So that possibly because of, the arrhythmogenic emboli that are releasing from the heart in patients with cocaine intoxication. And also cocaine, the vasculopathy is known to cause midbrain infarcts, which, Dr. Miller's case is going to highlight today evening. Thank you.
Thank you, Vivek. I think we must move on. I think there is a very important comment by Dr. Ambika, which I'll be really worried in these cases. Is that associated fungal infection which worsens the osteolysis than the cocaine abuse itself? So fungal infection is something I think we'll be worried, and we must rule out in all these cases. Thank you, Dr. Ambika. I think we should move on.
And thanks, Dr. Ramesh. So just before concluding, one quick question to Bart. You were talking about the crystals. That's on the histopathology, right?
Was I talking about?
You said that you have seen crystals in these patients. That's on the histopathology, cocaine crystal.
Yeah.
Okay. So thank you.
Yes. Yeah. These look like these sharp refractile crystals, and that cause a substantial inflammation immediately around the crystal. So it's like, a gout or pseudo gout or something like that. It's a crystal-induced inflammation.
Thank you. So with this,
thank you for your comments.
Thank you. Wonderful case and a great discussion. With this, we move on to the next case, which will be presented by Dr. John Chen. He is Professor of Ophthalmology and Neurology and Director of Neuro-Ophthalmology Fellowship at Mayo Clinic, Rochester, USA. He has over 200 oral presentations, including multiple named lectureships and visiting professorships. He also has over 200 peer-reviewed publications, many research awards, and is currently R01 funded through the NIH. He also has many prestigious achievements, such as AO Achievement Award, Top Doctors Award in Minnesota, the Heat Fellowship. He is also been recipient of the Best Teacher of the Year Award at Mayo Clinic 4 times. We all have been reading his work, and his key areas of interest are neuroimaging and neuro-ophthalmology, idiopathic intracranial hypertension, and optic neuritis, especially NMOSD and MOG antibody-associated disease. So I will unshare my screen and invite John to present his interesting case that will be moderated by Dr. Varshini Shankar.
Great. Well, thanks so much for that kind introduction and for organizing this wonderful meeting. And I'd like to present a case that we recently saw. The case is, how are you still seeing? I thought it had some good teaching points and was a good case to discuss here in this forum. This was a 77-year-old female who presented with 9 months of difficulty with vision. She had difficulty with reading. She was missing portions of her vision. She had some problems with her memory, some word finding difficulties, and some anxiety, but was otherwise fairly healthy at the time. The patient underwent cataract surgery and YAG with no improvement in the vision. They did have a TIA 4 years prior to presentation, and family history was remarkable for a sister with Alzheimer's disease. On exam in the Neuro-Ophthalmology clinic, she was 20/30 in the right eye, 20/40 in the left. There was no RAPD. In terms of color plates, she was only able to identify 1 out of 14 in both eyes. The slit lamp exam and the dilated fundus exam was unremarkable. Here, I'm just showing the OCTs, which show a pristine optic nerve in terms of both the arnophil and the ganglion cell. The visual fields are shown here, and you can see that they're very poor reliability. 46% false negatives in the left eye, 20% false positives, about 20% false negatives. But there was a little bit of a hint of a right homonymous hemianopia. You can see right here, most clearly on the pattern deviation, where just missing a little bit more vision on the right-hand side. But again, very, very poor reliability. On neurologic exam, the patient had some mild unsteadiness for gait with -1 for tandem, but Romberg was negative. On Kochman, sort of like that's what we use at Mayo, sort of like a mini mental statics exam. It was 27 out of 38, with most deductions from calculations, construction, and recall. And so this patient, in summary, has these vague visual difficulties, fairly intact visual acuity, normal eye exam, difficulty with color plates, and a possible right homonymous hemianopia with mild cognitive deficits. At this point, we knew it wasn't the eye. It has to be further back in the cortex. So the next step is going to be some neuroimaging. And the neuroimaging was fairly unremarkable for the most sequences. Here you can see the flare, and there's some scattered T2 changes that are nonspecific, as we'd expect for a patient in their 70s. What was interesting is this DWI sequence. So 4 years ago, she had that TIA kind of symptom, and there was this hint of DWI back then, thought to be not very specific, entirely sure what that was. And then 3 months into symptom onset, there was actually pretty prominent DWI signal. But then when we got an MRI, when we saw her, there was very little DWI signal that we could see. And we thought this was fascinating, but really, again, this was much more suggestive of a cortical processing issue. So we got a PET scan to kind of confirm that this was a processing issue. And what you can see is there's dramatic hypometabolism of the left greater than right occipital lobe. And this matches up perfectly with her right homonymous hemianopia and her difficulties with vision. It's clearly hypometabolism in the occipital lobe. And so we have our diagnosis of posterior cortical atrophy. And we all see these patients. It involves predominantly the occipital lobe, obviously the posterior cortex. The vast majority are going to be caused by Alzheimer's disease. And you can have something called the visual variant of Alzheimer's disease, where it's relatively preserved memory, but it's really the vision that starts off first. And you can have other degenerative conditions that can cause posterior cortical atrophy as well, including cortical basilar degeneration, dementious Lewy body, prion disease, subcortical gliosis. The age of onset is typically younger than full-blown Alzheimer's disease when you're presenting with just the vision symptoms. And the early symptoms are often nebulous, and I've definitely seen these patients get multiple surgeries. They get cataract surgery, they get epiretinal membrane peel. A very delayed, prolonged diagnosis in these patients is very common. And oftentimes the patient even thinks it's the cataract surgery that made my vision worse, but really it was posterior cortical atrophy that was progressing over time was invariably going to happen. The cataract surgery just, they actually probably didn't need cataract surgery at that time. And so in terms of the presentations and diagnosis, a lot of it has to do with history. They're going to have difficulty often reading, judging distances, identifying static objects within a visual field. Sometimes they'll have visual hallucinations. And then simultaneous nausea, I think, is something that we can key in on in the eye department to be able to help diagnose these. And this is that classic Boston cookie theft jar picture, where a patient with posterior cortical atrophy will have simultaneous nausea, and we'll be able to describe certain elements, maybe like this dish here, but won't be able to describe the whole picture as a whole. I think in the clinic, the most helpful thing to screen for it is actually our Ishihara color plates. So to be able to see this 74 in this orange and green kind of color montage, they not only have to be able to see the colors, but they actually have to be able to pick out the forest from the trees. And they can't actually often see these numbers. They might be able to kind of point at this and say, yeah, it looks green, but they can't actually realize that's 74. And so the Ishihara color plates, I think, are a great screening tool in the ophthalmology clinic so we don't miss posterior cortical atrophy. And anytime I see problems with Ishihara color plates in both eyes without an obvious explanation from an optic neuropathy, I usually follow up with this test here, which is the overlapping images, where obviously we all can see that there's independent objects, the fork, the cup, the tea kettle, but a patient with posterior cortical atrophy just really cannot identify this. Sometimes they'll just say, maybe there's a swan there or something like that. And I find this easier to quantify than sometimes the Boston cookie theft jar picture, where sometimes they can actually get it somewhat right, even though they're only seeing small pieces of it. Just over time, they can get it correct. And so what is the diagnosis in our patient? So we know the patient has posterior cortical atrophy based on the PET scan showing severe hypometabolism. All the visuals, eye tests are all pointing toward posterior cortical atrophy. The symptoms have been going on for 9 months. And again, the most common cause of posterior cortical atrophy is Alzheimer's disease. It's been going on for 9 months, didn't seem to be getting dramatically worse. Again, in my mind, I was thinking this is probably Alzheimer's disease. That's what we see all the time. But then you've got this cortical riveting, which has been kind of fluctuating. 3 months into symptoms, it was pretty prominent. And at that point, gosh, I was thinking that's got to be prion. But then now 9 months, when we're 9 months into symptoms, we're seeing them now, and it's pretty minimal. And so we thought that was interesting. So now our next step in terms of trying to differentiate Alzheimer's from prion disease, CJD, really should be a lumbar puncture, and that's going to be giving us our best answer. And so this patient was sent for lumbar puncture, and the CSF was elevated for 1433, which is a marker for prion disease. And really now are the most probably best confirmatory test prior to autopsy is your real-time quaking-induced conversion, RT-QUIC. And that was positive for CJD. And so this patient, despite having symptoms for 9 months without much progression, it was actually prion disease. Again, I thought this was very fascinating because I do see prion disease maybe once every other year or so. I see Alzheimer's disease once every 3 weeks. And so prion disease is much less common. And when I see prion disease and CJD, usually they progress so rapidly, and usually they're dead within 4 months. And so again, this was a little bit of a surprise, but again, that tip off of the DWI really kind of helped you there, at least think about prion disease. And so this patient has Creutzfeldt-Jakob disease, CJD. It's a universally fatal prion disease characterized usually by rapidly progressive dementia, ataxia, myoclonus. And in terms of the pathophysiology, we have these cell surface glycoproteins, and with prion disease, they end up getting this abnormal protease-resistant form that essentially the brain cannot degrade, and they just self-replicate, leading to widespread apoptosis and cell death, and invariably death to the patient. This patient had the Heidenhain variant of CJD, where the visual symptoms are first. And this is the patient that might end up in the eye clinic or the neuro-ophthalmology clinic, where it's just visual symptoms first. Obviously, if they've got very bad ataxia and myoclonus, they're not going to end up in the eye clinic. But again, if you have the Heidenhain variant, that can happen. It only makes up 5% of CJD. But again, we'll see it sometimes. The median survival of CJD overall is only 4 to 6 months. And again, all the cases I've seen prior to this one were dead, usually within 4 months. But the Heidenhain variant can sometimes have a little bit of a slower disease progression. And there's been reports of survival over 3 years. In fact, there's even one that had lasted even 7 years. It looks like, Neil Miller, you've got your hand raised there. Do you have a comment? I'd be happy to chat about it now.
No, I was just saying that in the chat that just like you, every case that I've seen, I'm aware of the rare ones, but boy, every case I've seen has been just rapid progression, not just from cortical disease, but you can have optic nerve disease as well that progresses rapidly. And the cortical disease progresses so rapidly in most cases that in many cases, the neurologists or the ophthalmologists think the patient is crazy because they're complaining and things are getting worse and worse, but you're not really seeing anything. On imaging, you're not really seeing anything in the eyes themselves.
No, I completely agree. In fact, I felt a little bit bad with my patient encounter with this family. It was a really lovely family. And again, it had been going for 9 months without a rapid decline. We had that MRI finding, and again, that made me a little bit worried about CJD prion disease. But Alzheimer's disease is so common. I was like, we've got to check, but this is acting more like Alzheimer's disease. All my other prior CJD patients just have such rapid decline, and so I felt bad that I didn't tee it up so high for CJD, and that's what it ended up being. Because again, in my experience, they've just progressed so rapidly. Just a little bit more background about CJD. The vast majority are going to be sporadic. There's this familial genetic form, 10 to 15%. There's the iatrogenic, which obviously we're always scared about. And then the variant from transmission from cattle, which fortunately we don't see as much or really at all anymore. But in 2000, late 1990s, that was pretty prevalent in the UK. In terms of the diagnosis, the clinical features, they're usually going to have myoclonus, rapidly progressive dementia, visual abnormalities, cerebellar dysfunction. So you're going to be looking for those. And again, usually it's very rapid. On MRI, we can look for the cortical ribbing, which isn't present in all cases, but if it's there, it can help you. The EEG, you can see periodic sharp wave complexes. On CSF, the old test was 1433, but as you can see, it's not that specific, only 80% specific. It can be high in a lot of neuroinflammatory conditions. But we now have RT Quick, and that has sensitivity of 90% and a specificity over 99%. So this is really kind of our way of diagnosing this condition prior to autopsy. And then, what really kind of confused us at first was this DWI fluctuation in our case. 3 months after symptom onset, you could see it was pretty prominent. When we saw him, it was very, very minimal. We looked in the literature, and there has been reports of decrease in cortical ribbing in CJD attributed to brain atrophy over time. What's interesting is we actually had our radiologist do an ROI, region of interest analysis. And what he found was that it was actually not a true fluctuation, but just a artifact in imaging brightness. So if we normalized it to, this area here, this is the first MRI and this is the subsequent MRIs, you could see the first MRI was a lot brighter, which probably led to that. But when you normalized it for the normal brightness, it actually wasn't brighter. So we thought that was just not a true fluctuation, but just a brightness imaging artifact. And unfortunately, our patient did pass away 1.5 years after onset of symptoms, just passed away actually last month. But again, much slower than we're used to seeing. So just some teaching points from this case. The homonymous hemianopia and simultagnosia are common posterior cortical atrophy. You want to have posterior cortical atrophy on the differential. If you have a homonymous hemianopia and you don't see an obvious cause on MRI, it really could be just cortical processing. Most commonly can be caused by Alzheimer's disease, but rarely can be caused by CJD, the Heidenhain variant. And occasionally you're going to have these slower disease progression. But again, not the norm. I think, as Neil had mentioned, these cases tend to progress very, very rapidly. So happy to answer any questions anyone might have.
Thank you, Dr. Chen. That was an absolutely wonderful case. There is one comment by Dr. Ing in the comments where he's asking how good of a test is auditory trigger myoclonus test? Does clapping the hands behind the patient elicit myoclonus?
Yeah, I think it can. Again, in our patient, it might not have because it was predominantly really kind of visual when we saw him. It was starting to spread to other cortices. The patient did not have myoclonus that we could trigger, but certainly in your classic, CJD that's very rapidly progressing, I think they will. But some of the ones in the eye clinic we see, if it's just the visual variant, probably won't early on.
Thank you. So I wanted to ask now when we see, because again, both these diagnoses are extremely unusual for us. Prion disease is something which we hardly ever see in the ophthalmic clinic, definitely. And posterior cortical atrophy is also an unusual, it's not something which comes to your mind the first time you see a patient, especially in a young patient with a near normal examination, except perhaps for the visual field. So I have a question from Dr. Ambika, where she's asking, do these patients with PCA worsen and progress over time? And sorry, we have a lot of comments. Yeah. So do these patients with PCA worsen and progress over time? And if so, how can they be differentiated from late onset retinal dystrophies? Because they have a near normal examination, particularly in the absence of cognitive problems. Do you always ask for a PET evaluation apart from a normal MRI?
Yeah, so again, I think the tip-off will be that simultagnosia. That's how we're going to probably pick them up in the eye clinic. If it's purely vision, then they're not going to necessarily have problems with dementia. And so the color plates, I think, for me, are a great screening tool. Again, they almost always struggle with that. And then anytime you've got a homonymous hemianopia that's unexplained on MRI, you want to think about posterior cortical atrophy, and that's when I might, switch over to a PET scan just to kind of confirm. I don't necessarily need it, but that simultagnosia is a good tip-off.
Thank you. Dr. Luciano.
And it does progress over time. That's one more thing. And then I think one more thing is I think some people are always looking for that young patient with purely posterior cortical atrophy. But a lot of the patients with Alzheimer's disease actually are missed. They've got mild dementia, and for some reason they're just missed because they're always, in the textbooks, they're always looking for that young patient with only vision symptoms. But a lot of our Alzheimer's patients will have elements of posterior cortical atrophy. So just, keep that in mind.
And Dr. Luciano has a question, and she's asking, what about the visual fields? Do they respond differently to static stimulus compared to kinetic stimulus?
Yeah, I think you can still pick up the homonymous hemianopia on manual fields, but it'll be a little bit more reliable. Like I bet in our patient, it would have been much more reliable. You saw on the PET scan, there was, a significant hypometabolism. They were really not seeing on that side very well. And so the manual field would be more reliable. But the automated, the poor reliability can actually help you kind of gauge that way. And then Neil Miller in the stat, I think, in the chat had a very good point. The color plates are great, but you have to listen to the patient to determine what they are not seeing. And it's so true. These patients, will struggle so much more than their vision when, their vision is often 20/20 or 20/25, and they are really struggling. And you just have to listen to them. I think sometimes even functional vision loss will jump up in the brain, but these patients are different. They are truly struggling. You can kind of tell them apart. And so that history is super important.
So I have a young patient who's about 55 years old, and the anxiety levels are very high when they first present to your clinic because everything seems normal for us to evaluate and all the tests come out normal. In fact, the first thing I had, which was abnormal, was he had a constriction of his visual fields, which could be detected only on 120 point, not a homonymous hemianopia. But the anxiety level is very severe. And I think one complaint which they frequently have is they have difficulty in daily navigation, moving around, driving a vehicle, accidents, frequent accidents. So when you suspect a posterior cortical atrophy, what would be your immediate approach? What kind of cognitive workup or cognitive testing are you going to order other than the PET scan?
Yeah, I think it's helpful to do formal cognitive testing because oftentimes you'll pick up some domains that are going to be affected, even beyond just the vision, and that's helpful. Again, I think as a general ophthalmologist, really you just want to be able to make the diagnosis and send them to a behavioral neurologist to kind of confirm. As neuro-ophthalmologists, we can do a little bit more. We can be getting the PET scan, we can getting the neuropsych testing. Vivek Patel said, and the NAVON figures are also a nice way of picking up simultagnosia. Bart said these patients can sometimes have prosopagnosia. They can't recognize faces. It's amazing how many visual symptoms can be involved in these patients. And yeah, in terms of how much to work it up, again, MRI for sure, that's necessary. PET scan if you have access, neuropsych testing, and your behavioral neurologist, it's always good. We have really busy clinics. Sometimes it's hard to kind of have that long discussion about this condition. Neurologists usually have a little bit more time than us, and it's a sensitive topic. You're diagnosing Alzheimer's disease, you're diagnosing potentially CJD. We don't have great treatments for these conditions.
Wonderful. Thank you, Dr. Jain. Dr. Sachdeva, any comments?
Oh, thank you. I think we had great discussion. But even though, these are very rare, but we all have to keep in the back of our mind, these could be the possible differentials that we are looking at a patient with possible visual field defects like a hemianopia and cognitive decline. But I think we have very little experience in dealing with this, but the case is illustrating everything very nicely. Thank you. I think in the interest of time, we'll move ahead. Thanks, John. Thanks.
Great. Thanks, everyone.
Okay. We'll move on to our next case, which will be presented by Dr. Amanda Henderson. So she is currently the Associate Professor of Ophthalmology and Neurology, and currently the Frank B. Walsh Professor of Neuro-Ophthalmology at Wilmer Eye Institute, Baltimore, USA. She has a lot of research interest, including optic neuropathies, specifically non-arteritic anterior ischemic optic neuropathies, high-value care, as well as using big data to answer neuro-ophthalmologic questions. She also has particular interest in medical education. She serves as the Associate Ophthalmology Residence Program Director, and she is also the Fellowship Director of Neuro-Ophthalmology at Wilmer Eye Institute, Baltimore. Welcome, Dr. Amanda. I'll unshare my screen and you can go ahead. Your case will be moderated by Dr. Veerna Shah.
All right. Thank you so much for that nice introduction and for including me in this interesting and important meeting. I will go ahead and share my screen here.
Yeah.
All right. Can you guys see it in full screen?
Yes.
Perfect. All right. So we will go ahead and get started with my case. I have a case of a 37-year-old woman who's presenting with 2 weeks of progressive vision loss in the left eye associated with pain with eye movements. She does have a pretty significant past medical history in that she has undergone 4 renal transplants starting in infancy for treatment of hemolytic uremic syndrome. She also has a history of hypertension and hepatitis C. And in terms of past ocular history, she had a vascular event, which had been called an NAION in the right eye, which had happened 12 years prior to the current presentation while she was on hemodialysis awaiting her 4th renal transplant. In terms of pertinent medications, she's on tacrolimus as well as prednisone. And aside from the vision loss and the pain with eye movements, she had no other new symptoms going on at the time of presentation. On exam, when I first met her, her acuity was 20/40 in the right eye, which was the eye with the previous vascular event, and hand motion in the left eye, which is the currently involved eye. She had a left relative afferent pupillary defect. Colors were down in that right eye, full motility and normal anterior segment exam. And here are her visual fields, and I put the ones from 2012 up for comparison, just to show that she did have a prior inferior altitudinal field defect that correlated with a vascular event, which was kind of not well reproduced on follow-up, but she had a new visual field defect, of course, in the affected left eye. On dilated exam, she had a pale right optic disc and she had grade 4 swelling in the left eye with cotton wool spots and hemorrhages associated with that nerve swelling, but the retina otherwise looked okay. And here are her retinal nerve fiber layer OCTs from the day of presentation to my clinic, where you can see that this really corroborates the right optic nerve pallor and the left optic nerve swelling. And so at this point, rather than do sort of all the questions and answers at the end, I thought we could kind of make this a conversation. And I was going to open it up to my discussant to talk a little bit about what the differential might be and what you might have as your next step of management.
Well, I would start by saying primary demyelination, but as the patient has been on long-term immunosuppressants, I think the possibility of opportunistic infections causing optic neuritis or optic perineuritis is a big possibility. Next, I would probably think about tacrolimus optic neuropathy, but I think it's unlikely in your case since it's unilateral presentation and associated with pain. I think infiltrative etiologies are always a differential. And also at this point, do you think we can list iris as a differential?
All right, certainly all good thoughts, and of course things we would all consider in this immunosuppressed patient with unilateral vision loss. So I'm gonna move on a little bit because it turns out I was sort of holding out on you guys a little bit. She had in fact already presented to an outside emergency department. So she did bring us a little bit more information. So she came to see me 10 days after she had been seen at a hospital, which is a community hospital sort of under the Hopkins umbrella, but not the Johns Hopkins Hospital. She had presented to that community hospital complaining of vision decline in the left eye and pain with eye movements. And she did get an MRI at that point in time. And so here you can see some coronal images from her T1 weighted post-contrast MRI. And here she has this really prominent enhancement of the perineural tissues around the left optic nerve compared with the right optic nerve, which looks basically normal or atrophic, but no active enhancement. Interestingly, on her MRI, she also had some flare lesions, which do look a bit periventricular in terms of their orientation. And so at this point, the emergency room, she was admitted to that outside hospital, and they got what seems like a reasonable start to a workup. And you can see that her serum inflammatory and infectious workup was pretty much unremarkable. She did have some sort of pancytopenia, if you will, which wasn't severe, but was previously present as well in terms of her chronic, in the setting of her chronic disease. She did get a spinal tap, which showed a normal opening pressure of 12, but the CSF was not normal and in fact showed high protein, high cell count, and mirror oligoclonal bands, meaning that the bands in the CSF were similar to those in the serum. So not particularly consistent with an MS diagnosis, but more suggestive of systemic inflammation. Unfortunately, during that hospitalization, it was never really determined quite what the cause of this abnormal CSF was. But she was seen by an on-call comprehensive ophthalmologist who went to the hospital and took a look at her. And she was also seen by the consulting neurologist that covers that hospital. And so they treated her for this sort of optic neuritis, perineuritis kind of presentation with steroid. She got 5 days of IV methylprednisolone, and then they sent her out on a prednisone taper. She was a complicated patient, and they're very good physicians, and they actually recommended that she transfer to the main Hopkins Hospital to see a neuroimmunologist and make sure there was nothing being missed here. But she was not excited about that option and declined that transfer and got her steroid and went home. And so when she came to my clinic, it was intended for her to follow up with a neuro-ophthalmologist, but the reason she ended up calling is that 10 days later, her vision was declining again. And so when she had been in the hospital, her vision was 2400 in that left eye. And as we mentioned already, when she presented to me, her vision was down to hand motion. So at this point, back to our conversation, how is the differential changed here? And is there any other testing you might order at this point?
So now I think with certainty, we can say that the etiology is definitely going to be infectious. Probably repeat neuroimaging, CSF, and probably the cultures. I think you mentioned bacterial and viral I think that leaves fungal.
Yeah, absolutely. So I put in the orders to get more neuroimaging, but in the meantime, we went back and looked at the neuroimaging she had and got our neuroradiologist to look at that neuroimaging as well. And it turns out, even on that original neuroimaging from the hospital, she had this leptomeningeal enhancement that you can see here on these T1 weighted post-contrast sequences, clearly suggesting that there's something going on here that is being missed. We did get a repeat CSF analysis, repeat LP and CSF analysis, which again had a normal opening pressure, this time 21, but a high cell count, a high protein, and this time the glucose was low. So as you suggest, at this point, it's really highly suggestive of an infectious etiology. And immediately the gram stain was sent and showed heavy yeast. So at this point, we strongly encouraged her to be admitted to the Hopkins Hospital, which she eventually agreed to. And because we were getting sort of a wide range of tests on the second lumbar puncture, we ended up getting cytopathology, which ended up showing these beautiful pictures of her Cryptococcus neoformans, which is what the cultures ended up growing out. So this was a case, an interesting case of cryptococcal meningitis, which sort of mimicked an inflammatory optic perineuritis. And I think these brain lesions, which were sort of periventricular in origin, kind of threw off the initial diagnosis and perhaps pushed that original team to go down the road of treating her as an optic neuritis, which I think unfortunately these brain lesions were a bit of a red herring and probably not related to her current presentation at all, particularly after we went back and reviewed her prior MRIs. So just a few words on optic perineuritis, and then a few comments on this case in general. Most of the optic perineuritis we see is going to be inflammatory, but infection is an important differential, particularly in patients who are immunosuppressed, like our patient here. I think most commonly what we see, at least in my clinic, with regards to optic perineuritis are conditions like sarcoid or IgG4-related disease, or even giant cell arteritis, which can look like a bit of an optic perineuritis, a perineural inflammation on MRI. But other infections like syphilis, like tuberculosis, particularly depending on where in the world you may be, and rarely fungal etiologies can also present this way. I think what's a bit less common with these infectious presentations is the lack of other neurologic symptoms our patient was having, which obviously confused this diagnosis a bit. So back to her clinical course, she was admitted and we got infectious disease involved. She was treated with amphotericin and flucytosine. And unfortunately, at this point, despite treatment, her vision loss in the left eye progressed to no light perception. But perhaps even more surprisingly, she remained otherwise well and didn't have any other neurologic symptoms or neurologic sequela from this infection. Her vision in the right eye, while she had that visual field defect, otherwise remained at baseline, and she never had any involvement of the other eye. So to summarize, in general, optic perineuritis has a broad differential diagnosis, which includes inflammatory, infectious, and occasionally neoplastic causes. Careful evaluation of the neuroimaging, which I think would have been quite helpful in this case, as well as further studies depending on the height of suspicion for infection versus inflammation versus other causes, can help guide the differential and make the ultimate diagnosis. Some cases do remain idiopathic, but I think particularly in immunosuppressed patients, we have to be very hesitant to say that infection has been adequately ruled out, particularly when some of the testing, like in her case, the LP results are abnormal. And in her case, clearly we don't know if she would have done better visually in the left eye if she had not received all those steroids, but I do certainly worry that, you know, if she had had appropriate fungal antifungal treatments to begin with, we may have been able to recover some of the vision in that eye. So I will turn it over to my colleague here and for any questions.
Yeah, thanks, Amanda. That was a lovely case, especially, you know, the patient didn't have any systemic symptoms, no fever, headaches. So it was a difficult case. And do you have any kind of a flow chart or something that you think we need to do to follow when you get a case like this? That, like, do you think culture should be mandatory in all cases? Like in India, TB meningitis is very common. So, you know, HRCT, quantiferon gold. I mean, we do these things here. Do you have any kind of a protocol?
Certainly. I mean, I think I think her initial workup, aside from not having fungal cultures included, was probably reasonable. I always get fungal cultures in cases like this, but I think really what I saw as the biggest concern here is that this patient was clearly at very high risk for infectious complications. And I think my threshold to start steroids would have been much higher. I think, you know, repeating the TAP and adequately ruling out infection was very important here. Of course, hindsight is 20/20, and it may be that, her fungal load was quite low at the beginning when she had the first tap. And clearly it wasn't seen on the gram stain the way it was seen on our gram stain later, but after steroids, she obviously had a much, her infection was clearly not under control. So I think it's a little hard to make a case like this into a flow chart just because it is so unusual. But I see the teaching point as, in patients who are very at high risk for infection, starting steroids should be delayed until infection is ruled out. And I did see a comment in the chat that perineuritis is very unlikely in MS. And of course, that's true. We would not expect this to be a perineuritis related to MS. But I think sometimes, we're neuro-ophthalmologists, so we see these things all the time, and that seems very obvious to us. But it may not be obvious to a comprehensive neurologist who's, covering call at a community hospital. So.
Yeah,
Yeah,
Dr. Virender, any questions from the rest of the panel?
Yeah. Thanks, Amanda and Dr. Vinna. I think we had great discussion in the case as we went along, but I think it's important for us to remember that there are some red flag signs for all of us. In an immunocompromised patient, primary demyelination would be less likely, right? So we need to keep that also in mind. And in fact, in the CSF analysis also, proteins were also elevated at the first CSF analysis also. That also goes against primary demyelinating disease. Possibly a more extensive workup, keeping a higher suspicion, as you just pointed out, would be important for all of us to keep. One more thing possibly that comes to my mind is that the patient's brain MRI lesions were slightly more fuzzy. There was a central clearing in one of the lesions. They are also not exactly too typical of a primary demyelinating disease. They are similar in periventricular location, but possibly little different. So we need to keep a higher suspicion in these patients, and CSF analysis with cultures would be possibly the way to pick up these earlier. These are my thoughts. Vivek, you were adding something?
Yeah, so I think it's quite difficult when we come across, as a novice case, even if you have done the first tap and, it doesn't reflect that there is something going really fungus inside, isn't it? Because most of the patients with perineuritis, if you rule out even the routine infections causes that we see here, I think non-response to the steroid is a crux of this case. And then you probably think again with high index of suspicion, do a second tap. And then you would, by that time, the fungus has quite enough there to get into the tap, and then you send it for gram stain. Quite interesting.
Actually, I had a discussion with a neurologist here, and he said that in patients who are immunocompromised, if you get a bland CSF culture, you have to think about some more sinister things happening. You have to be really careful.
Yeah. I would just like to add one more point here is that I had seen a couple of cases where patient was HIV positive, and there were two different pathologies. One was a secondary infection, and second one was like our demyelinating optic neuritis. So both had very huge difference in the CD4 counts. CD4 count in the immunocompromised patient with infection was less than 50, whereas the other one was around 500. So that kind of thing, beyond a particular level, below a particular level of CD4 count, the person may not be able to mount a demyelinating response or an immune response. That also could be helpful in such scenarios. These are my thoughts. Okay, I think we have covered all the points. There's another comment by Birds telling that he has also reported a similar case of cryptococcal meningitis in a patient with CLL. So again, an immunocompromised situation. So let's keep these unusual infections in mind when we are dealing with these immunocompromised patients. I think, thank you, and we'll move ahead with the next case. And for the next case with us, we have with us Bart Shawless. He'll be presenting the next case. He's currently Assistant Professor of Neurology, Neuroimmunology, and Neuro-Ophthalmology at Massachusetts General Hospital, Boston, USA. He participates in training of MEH neurology residents, autoimmune neurology fellows, and MEEI Massachusetts Eye and Ear Infirmary Neuro-Ophthalmology fellows. His focus area is inflammatory, infectious, and autoimmune disorders affecting the eye, base of skull, and the nervous system. And very pioneering thing is that he's the founding director of Inflammatory Neuro-Ophthalmology and Skull-Based Disorders Clinic there. So welcome back. I'll unshare my screen and you can go ahead with the case.
All right. Well, thank you, Dr. Werner, Dr. Satya, for inviting me and for organizing this beautiful conference. It's really become something that I look forward to every year. So allow me to share this case, which I entitled A Headache Nightmare. And so this is a case of a 22-year-old young man who presented with several months of headaches induced by exercise and awakening from sleep. And so specifically says that he wakes up from a nightmare and then he has these brief 10 to 20 second stabbing headaches, and he notices that during the headaches, he has associated lid drooping and pupil change. So he actually provides a selfie of himself during the attack. And you can see the problem here is in the left eye, where there's a relative meiosis and a ptosis. So in other words, he has a paroxysmal Horner syndrome during these attacks, but not present in between the attacks. So on exam, he has a very benign neuro-ophthalmic exam. He has normal vision, color vision, visual fields, and his lids and pupils, as well as his extraocular movements and his fundi appear normal in clinic. On general exam, he is mildly hypertensive. He's a very tall individual. There is a nasal voice quality, and he does have enlarged tonsils, which he says is a recent problem. The cranial nerve exam was normal. So what's the diagnosis here of these brief 10 to 20 second stabbing headaches with associated lid drooping and pupil change? So the diagnosis here from a headache perspective is what we call SUNA, or short-lasting neuralgiform headaches with autonomic changes, which is a kind of trigeminal autonomic cephalalgia. So this is the general category of headache disorders that we're talking about here. These are all headache disorders that do present to neuro-ophthalmologists because they're uncommon and not many doctors necessarily know about these disorders. And so it's a family of disorders that includes cluster headaches and includes paroxysmal hemicrania and hemicrania continua. All of these tend to be one-sided headaches that are associated with some autonomic changes, such as Horner syndrome, at least some of the time during these attacks. The main distinguishing points are the duration, which is different between these, with SUNA being short-lasting, and the response to treatment. So just SUNA, what we're talking about here, there's these two types of short-lasting unilateral neuralgiform headaches. SUNCT is with conjunctival injection and tearing. SUNA is with cranial autonomic symptoms. SUNCT was described in 1978, and then they were separately included in the International Classification of Headache Disorders in the second edition, 2004. But in the third edition, they were then brought together as two subtypes of the same disorder. So there's a lot of overlap between these two subtypes. So these are TACs that are rare. These are quite uncommon disorders. They can present at any time, but most typically in middle age, with a slight female predominant, and they're characterized by these sudden brief attacks in the trigeminal territory, usually V1 or V2, with autonomic features, either single stabs or there's a plateau with overlying stabs or repetitive stabs, and some patients have a periodic recurrence of these attacks. Some patients also describe triggers like touching the face or washing the face or Valsalva or something like that. And they usually have a normal neurologic exam, although some patients do have trigeminal sensory abnormalities, either increase or decrease sensation to pinprick. This patient did not. So how do you figure it out? Well, you have to distinguish between the other TACs, and you can use other medications, for instance, to do that. Indomethacin tends to work very well for hemicrania continua and paroxysmal hemicrania. Oxygen tends to work for cluster headache. These disorders often respond to lidocaine infusions. And always keep in mind that as with all the TACs, this can be a primary headache syndrome, but it can also be secondary to intracranial pathology, which often is in the cellar area. So are there any further clues of what might be going on here? Well, there is the tall stature, the new enlarged tonsils, and on further questioning, he also describes jaw and hand changes. So maybe you can see, there's this enlarged nose, he's got an enlarged lip and enlarged chin. And these on questioning are changes to his facial structure that are relatively recent. So further workup is obtained, starting with imaging. So we're looking at an MRI of the brain, T1 post-contrast in the coronal and axial plane. And so what we're seeing here is a very large mass in the cellar area that is extending both upwards and laterally into the cavernous sinuses. And so that is biopsy then. And what we're seeing on pathology here is a hypercellular mass. You can see that there are some mitoses present here. Here I'm showing an H&E scan together with a Ki-67 stain, which is a marker of cellular proliferation. So it's a modestly hyperproliferating mass here. And then it's stained for growth hormone, as well as for this marker here, which of a low molecular weight keratin that tends to be associated with glandular tissues. So this is a growth hormone producing tumor. There's also a slight staining for prolactin, but a negative staining for the alpha subunit. On serologic workup, the patient has a mild elevation of prolactin, which is probably from a stalk effect, and a more substantial elevation of growth hormone on IGF-1. So the diagnosis here then is a lactosomatotroph adenoma producing growth hormone and prolactin, causing both acromegaly and a secondary trigeminal autoencephalgia, namely SUNA. So the patient then did well with resection and radiation, and then he was started on octreotide, so a somatostatin analog that is used for growth hormone producing tumors. And interestingly, that as soon as you started on this medication, the same headaches occurred, these sharp stabbing occurring out of nightmares over exertion with a paroxysmal Horner syndrome. So I thought that was quite interesting. Octreotide has headache listed as a side effect, but it has also been studied for headache relief, both for analgesic effect in pituitary adenomas and in things like cluster headache, and has been proposed as a treatment for IIH, but it's not effective in migraine. And just to make the case here of this secondary trigeminal autonomic cephalalgia, this is another case of a young woman who presented with cluster headaches, which to all intents and purposes looked like, by description, a classic cluster headache, except the demographic is different because it tends to be not a problem of young women, but rather older men. And she actually also provided a selfie during the attack that showed the paroxysmal Horner syndrome and a little bit of redness around the eye. But in between attacks, she continued to have a Horner syndrome. And so we obtained imaging, and what you see here is on both the T2 and the T1 post-contrast imaging, there's abnormality of a superior rectus levator complex. So now she had an orbital myositis, and she responded to steroids, and her cluster headache syndrome completely went away. So the lessons here are that, number one, skull-based disorders can mimic primary headache syndromes, and that 10% of these trigeminal autonomic cephalologists can have an intracranial lesion frequently in a cellar area, although I just showed you a case where it was a different area in the orbit. And don't forget about the neuroendocrine review of symptoms in appropriate patients.
Thanks, Bud. A very interesting case. I think we started with headache and we still are landing up with headache despite everything. But as you rightly said that as neuro-ophthalmologists, we might be seeing many of these patients. One of the important goals for us is to distinguish between the primary headache disorders versus those related to intracranial neoplasm. And some of the clues that you were highlighting were like the patient did report change in the facial features that were there. And there was recently enlarged tonsils. So possibly that was interesting. at least we do get a visual field in such doubtful cases. So did we have any visual fields for the patient at presentation?
The patient did have visual fields. I mentioned it very briefly. They were normal to confrontation initially, and then the patient had the resection very quickly. Subsequently, he had a visual field in clinic, and then he had a slight defect and then normalized. It wasn't done right away because of the way that the patient was triaged through the emergency room. Ultimately, he ended up with a completely normal visual field after treatment.
Thank you. And do you think that in this patient, the autonomic symptoms and the transient Horner syndrome that were coming in the context of everything, is it now likely to be the trigeminal autonomic ephalgias or more likely to be the effect of the tumor?
So I would call this a secondary trigeminal autonomic cephalalgia, meaning to all intents and purposes, it is the same as a primary trigeminal autonomic cephalalgia, which occurs idiopathically, but it is triggered probably as some sort of trigeminal reflex that is caused by irritation of the meninges around the tumor or something like that. But it's a secondary headache syndrome.
So possibly like the lateral extension into the cavernous sinus is irritating the trigeminal branches there, that's causing?
So it could, in some of the literature, the tumors are relatively small, so it doesn't even have to extend into the cavernous sinus, but even the cellar area has a meningeal covering called a diaphragma cella. And so, maybe that is, if that is pressed and expanded, in some cases may trigger these trigeminal reflex pathways that then present as one of these disorders.
Thank you. And what about how would you manage now this patient? Like octreotide was given, in relation to the patient's endocrine profile, secreting the hormones. So how would you like to treat that in case the patient is getting headaches? Would you still continue, or would you recommend some other treatment?
Yeah, eventually he was switched to a second-line medication called lanreotide. So, and eventually his headache syndrome normalized, and I've been following him for now 2 or 3 years, and he's had very stable MRIs, very stable visual fields, and his facial appearance actually got much better too.
Thank you. Any other questions from any other panelists? Anybody would like to share any experience or add?
Yeah, I was wondering, with the IGF-1 elevation, is there any role of teprotumumab?
That's a great question. I mean, the IGF-1 is a classic test that we use to check the growth hormone axis, because it's much more sensitive actually than checking the growth hormone, which is present in minuscule quantities only in the blood. And so that's part of the testing. I don't know if anybody has looked into teprotumumab for these pituitary adenomas. I would have to look at the literature, see if that has been, if that can be used as a therapeutic pathway.
Thank you. There's one more question. Dr. Ambika has shared a question in the chat that do you get a MRA head and neck in such cases of paroxysmal Horners, particularly with history of headaches, with history of exercises in addition?
So that's a really good question. The recommendation from the literature is to get an MRI because a lot of times there's intracranial lesions and they're often in the cellar area. If there's a persistent Horner syndrome, I think there's no doubt that you need to get vascular imaging. If there's a paroxysmal Horner syndrome and the patient has normal lids and pupils outside of that during the exam, I'm not sure, it's probably not wrong to always get the MRA, but I don't know that you're necessarily required to get the vascular imaging. If it's a persistent Horner, then of course, no doubt. And then the second case was also to remind us that probably any lesion within the trigeminal nerve distribution can sometimes trigger these abnormal reflex disorders. And so that includes the orbital area and facial area. So sometimes maybe get an orbital image as well.
Thank you. So continuity of that, could the lesion that is causing the Horner's, could that be initially be leading to a transient symptoms, and we could pick up by imaging?
Could the lesion cause more? I'm not sure I understand the question.
What I was trying to say was that before the lesion becomes permanent, we could be having transient episodes of Horner's, and would the imaging in vascular imaging would also be important in such a case. Like in this case, we found a lesion in the cellar area. If that is not the case, would you have still done it?
That's a good question. These are rare disorders. I mean, I have a limited experience, and I think that most people outside of maybe great headache experts will see these relatively uncommonly. But other TACs like cluster headache are more common. I don't think that I would extensively image every patient with a classic cluster headache syndrome. They get one MRI, maybe with some MRA of a head and neck, maybe the first time. I think I would have to take it on a case-by-case basis. But these sooner are very uncommon. But they can be just a primary headache syndrome without any secondary pathology, and you just manage it as a headache.
Yeah, thank you. I think we'll conclude this case here. Thanks, Bart. Very good case. We'll move ahead next to the next case, and we have Dr. Neil Miller, who will be presenting the next case. So all of us know Dr. Miller very well. Dr. Neil Miller is actually Professor Emeritus, the Frank B. Walsh Professor of Neuro-Ophthalmology, Neurology, and Neurosurgery at Johns Hopkins University School of Medicine, Baltimore, USA. He has a hopping number of contributions to the field of neuro-ophthalmology, over 580 articles, 97 chapters, 15 books, including the 4th edition of Walsh and Hoyt's Clinical Neuro-Ophthalmology, which we all follow. He has also co-edited the 5th and 6th editions of this textbook, and he has also made an abbreviated version of the textbook Walsh and Hoyt's Clinical Neuro-Ophthalmology, The Essentials. He has also co-authored 2 editions of Neuro-Ophthalmology Survival Guide, a textbook designed for both physicians and students. And he has been an invited speaker both at national, international meetings, and has given 65 named lectures around the world. He has trained many of the neuro-ophthalmologists around the world. Welcome, Dr. Miller. I'll unshare my screen, and over to you. Dr. Vivek Varkad will be moderating the session.
Trust you can see the screen. Good. So I want to first begin by emphasizing that this is actually Dr. Drew Carey's case, but it was presented to me by our fellow from last year, Jay Patel, and I thought it was worthwhile presenting for several reasons. First, for many years, I've talked about the ocular phenomenon that we're going to see in a few moments. And I've been trying to convince or teach the residents and the fellows to look for this phenomenon. I've only been partially successful. The other issue is that this phenomenon that you're going to see is the best example I have seen in my career. I apologize if others of you have seen this all the time and it's no big deal, in which case you can relax and not pay attention. In any event, this is a 68-year-old woman with a past medical history of hypertension, diabetes. You can see it there. She was HIV positive, had gout. She'd had a hysterectomy in the past. She used tobacco, and like Hades' case, she was a cocaine user. She had no allergies, and you can see the medications she was on. She was found unresponsive at a local fast food establishment with a blood pressure that you can see was quite elevated. She was given Narcan and taken to a local hospital. At the hospital, she was found to be aphasic. She had right-sided hemiparesis, Both her blood and urine were positive for cocaine. And a CT showed, as I'll show you in a moment, a left thalamic intraparenchymal hemorrhage with extensive intraventricular extension. She had a DSA that was negative for aneurysm, but an MRI showed multiple punctate abnormalities in the frontal, occipital, and cerebellar area consistent with infarcts. And here's the MR, and you can see this very large lesion in the region of the thalamus going into the midbrain. And on the SWI, you can see the extent of the obviously hemorrhagic lesion. So she was diagnosed as a thalamic intraparenchymal hemorrhage due to her hypertension and either a cocaine and related vasculopathy, or maybe an arrhythmia had caused embolic infarcts associated with the cocaine use. She was placed on aspirin and atorvastatin and discharged after 5 days of intubation and a rehab stay of 23 days. Her hospital course was complicated, as you might have predicted, by blood sugars that were difficult to control, and she had a serratia pneumonia. But during her rehab stay and thereafter, it was noted that she had difficulty seeing to the right, which was not all that surprising given what her MRI showed, but she also had a very wide stare. She was eventually discharged from the rehab and referred to us at Hopkins. When she was seen, she was alert, well-groomed, but in moderate distress. She had no lymphadenopathy or sinus tenderness, cardiovascular, pulmonary, GI, everything was fine, but her neurologic exam showed aphasia. She had a right-sided weakness and actually came in with a cane. Her skin and extremities were normal. On neuro-ophthalmic exam, she had normal visual acuity, more or less, normal color vision. She had an incomplete right homonymous field defect. She had a mild right RAPD. Slit lamp showed some cataracts, tensions were normal, ophthalmoscopy was normal, but what was really interesting were her eye movements. Here's her visual fields. You can see the right homonymous. So look carefully and let's look at her eye movements. And Drew is testing both pursuit and saccades. You can see her horizontal pursuit, her horizontal vertical pursuit. Terrific. Now let's watch her saccades. No upgaze whatsoever, except on pursuit. I'm going to show that one more time. So we're testing pursuit first, including upgaze and downgaze, and then saccades. Okay. So this is vertical pursuit saccadic dissociation. It's most often seen in dorsal midbrain syndrome. We've all seen patients with Perronneau syndrome, just like Miller-Fisher syndrome that was discussed earlier. You can see all are part of the abnormalities: convergence, retraction, nystagmus, pupillary light near dissociation, lid retraction on attempted upgaze, which in some cases is simply an epiphenomenon because the patient can't look up, but the lids can go up, and an upgaze paresis that you can miss if you only test pursuit. This is a pursuit saccadic dissociation, and if you don't test for both pursuit and saccades, you're going to miss the potential supranuclear nature of the abnormality. And so many times I've been called by both adult and pediatric neurology when they have a patient who has a pineal region lesion, and they say, well, the patient has a little bit of abnormality with the pupils, but the eye movements are fine, and we don't understand why the eye movements are fine. And it turns out all they have tested is pursuit, and they haven't tested saccades, so they haven't recognized the upgaze, the isolated in the respective ocular motility, the isolated upgaze abnormality. Now, the issue comes up as to where the problem is. And at least what I've been taught, is that the real problem is in the posterior commissure, where you can have unilateral or bilateral, unilateral lesions of the thalamus coming down to the posterior commissure, or the commissure itself, that can cause unilateral or bilateral upgaze paralysis for saccades, but not for pursuit. And this is from an article that shows this sort of in color of the areas that are important in saccades versus pursuit, the saccades in red and the pursuit in green. And you can see that it's the PC and the posterior commissure, probably not the RIMLF, even though these show it, because as my understanding, and maybe somebody can correct me, lesions of the RIMLF not only cause vertical gaze problems, but torsional abnormalities. And so, as far as I know, it's the posterior commissure that can cause an isolated upgaze paralysis for saccades. So I wanted to share that case, and Vivek may have some comments about these issues. Thanks.
Yeah, thank you so much, Dr. Miller, for bringing this very interesting case. And as you said, although the motility, the video what you have shown looks very simple, but it's so powerful. When the resident and fellows they would develop that habit of looking carefully, not just to look at the saccade or just a pursuit, or vice versa. So basically, we need to be very careful when we look at the saccade as well as pursuit. So as he has highlighted, if you go by just looking at a pursuit, this case looks absolutely normal. You wouldn't end up with localizing where it's going wrong. But when you look at the saccades, there is a clear cut, the upgaze palsy. And that's how the careful look for how the lead get retract. When you ask the patient to look from down to primary gaze, the lead shoots up. So I think that's very much localizing for the posterior midbrain syndrome. And I completely agree with you. An isolated lesion with the posterior commissure will have more kind of the paralytic saccades rather than RIMLF. RIMLF, along with, if it gets like interstitial nucleus of Kajal, then we will have then additional feature of getting their vestibular ocular reflex getting affected. So I think that also we need to keep it in mind simultaneously. I just wanted to ask, with your vast experience, and I think you have already written a lot on this topic. So what is your experience of, the patients with this classic perinode signs in children's? Like, what etiology you had seen more often? Because adult, we know that this particular patient was a very typical, hypertensive, and they do usually because of, the midbrain hemorrhage. So what's the cause in pediatric population?
Actually, we published a paper a few years ago with one of our fellows where we looked at the patients with perinodes over a 10-year period. And not the vast majority. There were only about 26 patients. A lot of the patients had just hydrocephalus in general, or decompensated hydrocephalus, decompensation from a shunt. But of the patients who had pathology, 7 of 26 had germinomas. And it was interesting to us that the rest of them, pinealomas, pineoblastomas, et cetera, I would say that that overall, the majority of patients with Paranose syndrome that I've seen over the years have simply had congenital hydrocephalus with a shunt failure. I think that's by far the most common. But if you're talking about structural lesions, then it appears to be germanomas. The other interesting thing is that the reason we published a paper was to determine if you could see any risk factors for Paranose syndrome in patients with lesions in the area of the dorsal midbrain. And it turns out if you see intrinsic brain abnormalities of the midbrain itself, you're more likely to have a Paranose syndrome, and it's less likely to improve over time.
Yeah, I think that's a great comment. Just to add my experience, I had a child who had, the history of the birth trauma where, there was the posterior midbrain had a hemorrhage during the forceps delivery. So this particular child had presented with a very typical feature of perinods. And last week, I had seen a 12-year-old boy who presented with pineal gland, the mass lesion presenting with a very typical sign of, the upward saccade with the lead retraction. If there are any comments or expert opinion from the panel or...
Yeah, one of the things I'd be particularly interested in is whether the panel thinks that this was a problem directly with the posterior commissure or whether it could have been the descending fibers down through the thalamus, because the main issue was in the thalamus. It wasn't as much in the dorsal midbrain. There was some evidence of it, but I wondered about that. And the other is, it's fascinating to me that the posterior commissure, if you truly damage it, you're going to see both upgaze and downgaze saccadic paralysis, whereas this patient clearly just had upgaze. So I just wonder if this was less precise in terms of direct damage to the PC and rather something with descending fibers, but I honestly don't know.
Yeah, I think I was reading the literature, with the same question in mind, and it's not, sometimes it's kind of like all three, RI, MLF, then INC and the posterior commissure. So sometimes rarely they do have, the downgaze palsy as well.
Yeah, I agree. I don't think I've ever seen a case, maybe somebody has, I don't think I've ever seen or at least not recognized a case of pure saccadic paralysis downward. It's got to be extremely rare.
Yeah.
Thanks, Dr. Miller and Vivek. Great discussion. I think we should all pay attention to the point that you have highlighted, looking at the saccadic and the pursuit movement separately. Personally, I think I have not paid attention to it. I will pay attention in future more carefully. Thank you.
Thanks, Pravendra. Thank you.
Thank you.
So we'll move a question in the chat.
There was a question about can they have diplopia? Can the patients with Paranose syndrome have diplopia? And
oh, absolutely. And it's interesting that you bring that up because you might think that they shouldn't have diplopia because there's a bilateral process, but it's not all that unusual to have some strabismus as part of that. Almost always it's vertical. And I don't know in some cases whether it's simply part of a decompensated phoria because of the problem. We had a patient who presented a few years ago with a Paranose syndrome with diplopia, who turned out to have a pineal region lesion that was biopsied and found to be sarcoid. So almost anything can occur, but yes, I've seen a number of cases over the years with diplopia as part of the Paranose syndrome.
Thank you.
Yeah, I think they do present with sometimes disc edema as well as sixth nerve palsy because of the very the region, the pineal gland tumor, which is causing
Right.
Can the diplopia be managed with prisms?
Yeah,
I've had pretty good success with prisms, actually. The press-on prisms, I never, almost never prescribe ground-in prism because you never know what's going to happen over time. But these inexpensive press-on prisms can work surprisingly well.
Another comment which is there is that they can have diplopia because if there is skew that is associated. Dr. Vivek Patel.
Absolutely. Midbrain skews are not uncommon.
And so possibly as Dr. Priyadarshini raises a point, if these prisms cannot manage, what would be the approach? Would you recommend a surgery to correct the primary deviation?
I'm trying to think if I've ever operated on a patient with a paranose for that. It sort of depends. It's sort of like third nerve palsies. It depends on the severity of the process and whether you think they're going to get better or not. I would certainly wait at least 6 to 8 months to see if things would improve and make sure everything is stable. But I think you can do it. It's a little bit like operating on CPEO patients. Traditionally people say not to do it, but indeed you can do it. It all depends on whether once you've waited long enough, whether there's limitation that's mechanical over time, or whether it's the force ductions are perfectly fine. And the only thing I would say is that what I was taught to do was to do much more than you would for a standard strabismus. The patients need a lot bigger recession or resection than you would think for the amount of deviation.
Yeah, I think if we can bring the strabismus where the prisms can easily help. You can always consider that. Considering other aspect where we usually tend to practice the prism post-operatively.
I agree.
Yeah. And we could do a subjective assessment also where the patient is using before and then titrate. Could try adjustable sutures if finally after a particular period of waiting we decide to operate. Thank you. Thank you, Dr. Miller. Thanks, Vivek. So with this, we'll move on to the next case that will be presented by Dr. Vivek Patel. Dr. Vivek Patel is Vice Chair of Academic Affairs, Professor of Clinical Ophthalmology, and Chief of Neuro-Ophthalmology and Adult Strabismus at University of California, Irvine, in the Gavin Herbert Eye Institute. He is currently also Director of Neuro-Ophthalmology and Adult Strabismus Fellowship at University of California, Irvine. He is also co-director of Neuro-Ophthalmology and Orbital Surgery International Fellowship. He is examiner for American Board of Ophthalmology and associate editor of the Journal of Neuro-Ophthalmology. Welcome, Dr. Patel. I'll unshare my screen and over to you.
Thank you, Dr. Vinder. Pleasure to be here. I'm just going to pick up my presentation here. Give me one moment.
Dr. Jyoti Matalia shall be discussing the case with you primarily and leading the discussion.
Perfect. Just 1 second. It just, for some reason, it closed on me, but give me 1 second. Virender, can you see it?
Yes, we can. It's not in slideshow, I think, still. Yeah, now it is in slideshow.
Okay, now we can start. Okay, thank you again. Always a particular challenge and pleasure to follow Dr. Miller in any context, but I'll do my best here to give you, it's actually not one case, it's 3 cases that presented with a common diagnosis and really nothing exotic as we've seen in some of the other cases, and not a special diagnosis, but important enough to keep it in mind because it's a common diagnosis with emphasis on presentations that are slightly less common in a presentation. So this was a 25-year-old PhD student that I had seen some time ago who had come in with a primary, no diagnosis at this point and no prior medical history, but he came in with a complaint of, I cannot move my eyes. So what you can see here will be just the inability for him to look to the right. He's trying to look to the right. Both eyes cannot look to the right. He looks up and down just fine. And then he cannot look to the left either. He's trying very hard to look to the left. So either direction, he cannot move either eye. And then with Dulles head maneuver or the VOR, I'm having him look at my nose, and you can see that he's not able to overcome that deficit. So he has what we would all recognize as a bilateral gaze palsy, not overcome by the VOR. So we could localize this quite well and just go back to your anatomy, of course, and this talk will be entirely about just correlating neuroanatomy with the clinical findings. And we can see that this is actually where the lesion was. This young man had this lesion right in this spot here. I'm blowing it up. You can see this upside down heart right here where both abducens nuclei are in the brainstem at the pontomedullary junction. And it correlates exactly on this diagram with those nuclei over here. So he has a bilateral abducens nuclear lesion. And we all know that an infranuclear lesion, whether it's the fascicle or the peripheral nerve, should give you an ipsilateral abduction weakness. Nuclear lesions give you a conjugate gaze palsy because of the internuclear neurons that give rise to the contralateral MLF that are involved in addition to the abducens fibers. And here we would think this would be a conjugate horizontal gaze palsy, interestingly bilateral, as his first presentation of a neurological syndrome. And we also know the VOR can help us overcome any lesion that is above, from an organizational standpoint, above the 6 nerve nuclei. So the PPRF with a paramedian pontine reticular formation or cortical lesions can be overcome by using the VOR, and therefore they should have better excursions in the direction of the gaze palsy if you elicit the VOR. But if it's a 6 nerve nucleus issue, then you cannot, because that's the final motor pathway. And of course, we did an MRI, and it showed, in addition to that lesion there in the brainstem, you showed some paraventricular lesions that are quite common and quite indicative of multiple sclerosis. And that was his first presenting features of MS. And a few weeks later, after the IV solumetrol and some time to heal, he has a full recovery of his horizontal eye movements. So this is his new diagnosis, so bilateral gaze palsy. Just wanted to point that out in terms of how we use the ocular motor examination that we're doing every day to pick this up. This is another case of a man who already has a diagnosis of multiple sclerosis, but I'm going to just show you a video here to point out a few features. You're going to see a bilateral INO, which is obviously very obvious in this case. We know that more subtle INOs may have a full duction, but we use the saccadic velocities to allow us to determine if there is actually a paralysis. In general, we know that many conditions can cause a limitation of eye movements to range. For example, thyroid eye disease, myasthenia gravis, many other things can actually give us a limitation of the range, but a reduction in velocity is generally a paralytic cause. And so if you look in between the two eyes, generally speaking, I like to kind of look at it this way. If I look between the two eyes at the bridge of the nose, you can see both eyes at the same time, and you get a better appreciation for relative changes in velocity between the two eyes. Here it's easy because he has a duction deficit, but you'll also see if you look between the two eyes that there will be an adduction slowing bilaterally. And then when I get on to show you the actual vertical eye movements, you will see that there is an upbeating nystagmus. I'm prefacing it because it can be hard at a first pass to be able to see all of these things. So here he is looking straight ahead, now trying to look to the left, and then he has an adducting slowing when he comes to the primary position. He has the abducting nystagmus as well, as you see, generally speaking, in an INO. And then when he comes back to midline, he has an adduction slowing, right? And you can see that when you look in between. Now watch when he looks up. When I have him try to look up, it's hard to obviously to video this perfectly because we're looking at iPhone videos here in the clinic. But you'll see there's an upbeating nystagmus, obviously more prominent in clinical practice, but it's there. And there's an upbeating nystagmus, very common with these INOs, in particular bilateral INO, and that's why I bring it up. In down gaze, he didn't have any real particular nystagmus, a few upbeats, but much more prominent up gaze. So he has a bilateral INO with upbeating nystagmus, okay? Now, this is just a very simple diagram to show the relevant features. we know that our static eye position is partly influenced by the balance between the semicircular canals. For example, for vertical eye movements, there's a relative balance between activation of the anterior semicircular canal and the posterior semicircular canal, so our eyes don't drift up or down in the context of a slow phase. But keep this in mind, the anterior semicircular canal sends a positive input, this is just normal anatomy, to the superior vestibular nucleus in the rostrum medulla. The superior vestibular nucleus has a tract called the ventral tegmental tract, which goes up the brainstem, and you'll see this parenthetically, that it goes parallel to the MLF, which is what's relevant in this case. So the superior vestibular nucleus sends input, of course, to the elevators of the eye, because when we have activation of our anterior semicircular canal, that's usually when we pitch our head down, so the eyes have to go up. So the superior rectus and inferior oblique are, of course, our elevators. There is a direct tract between the superior vestibular nucleus and the superior rectus inferior oblique. Okay. Now, in a situation like this, where we have a lesion, which we're not surprised by, we have a lesion in the region of this brainstem, as you can see here in the dorsal brainstem. This is a lesion here. You can see that. Now, of course, then we're going to not have this elevation, right? The superior rectus and inferior oblique are not going to get the input from the superior vestibular nucleus. Therefore, there's a tonic downward drift, because the upward drift that should balance the downward drift is not there. So there's a downward drift of the eyes, and the corrective fast phase will be upward. So the upbeat nystagmus is seen due to this interruption of the ventral tegmental tract, which is in parallel with the MLF. And that's why it's common to see with bilateral INOs, common to see upbeat nystagmus. Just wanted to point that out. Third case, and this was again a patient who does not have a diagnosis, comes in with an acute problem. So case 1 and 3 are essentially a new neurological presentation. She was a 34-year-old woman coming in with acute binocular vertical diplopia. She has diabetes, a genetic form of type 1 diabetes, has a family history of multiple sclerosis. She had remotely a Bell's palsy that resolved that we didn't think was connected, but in retrospect, you don't know, but essentially that was part of her history. And her review systems, in addition to the vertical diplopia, was she had left periorbital paresthesias, altered sensation on that side of the face, and some disequilibrium, maybe due to a vestibular problem, maybe due to the diplopia, some combination thereof. And here I'll just quickly go through the afferent examination, which was entirely normal. Although we did think that there was an early escape kind of APD on that right side, didn't bear out on the RNFL analyses or so forth, but be it as it was, felt clinically speaking that there was a slight afferent deficit, but really not the presenting complaint or anything that we could really see on the examination, okay? Really no pallor, nothing else that was really obvious. Okay, now again, very short clips, hard to video, but here I want to show you that she has an asymmetric gaze-evoked nystagmus on the horizontal plane. So you will see a pretty obvious right beating nystagmus in right gaze, left beating in left gaze. But what you will see is that on right gaze, it's a slightly higher frequency, lower amplitude nystagmus. And when she looks to the left, there's a higher amplitude, lower frequency nystagmus, although it's relatively intense in both fields of gaze. Okay, so you can see that it's relatively high frequency. And then when she looks over to the left, when she sort of settles down, the amplitude was a little bit higher and not quite as frequent. And that was something that was a little bit more obvious in the clinic, but able to see that. Now, when we see that gaze-evoked nystagmus with a vestibular bias, we call that a Bruns nystagmus, correct? And that Bruns nystagmus is incredibly good localizing value, and it's probably there much more commonly than we see in patient charts. And we know that generally speaking localizes to the cerebellopontine angle on the side that has the higher amplitude nystagmus. So in this situation on the left, and that's probably due to an impaired gaze holding. So we know we have the horizontal gaze holders and the vertical gaze holders, which we were alluding to in the previous presentation. But for horizontal gaze, in left gaze, for example, her medial vestibular nucleus and her NPH, or nucleus purposive hypoglossus, has to work to hold gaze in left gaze. On the right side, her NPH and MVN on that side have to work to hold gaze in that direction. So when we have a lesion in the left cerebellopontine angle, that likely is affecting the medial vestibular nucleus, and therefore there's impaired gaze holding on that side. Therefore, the higher amplitude nystagmus. And that's what we're seeing in this situation. The point is that we can see all of these abnormalities in a given individual, but if they come together in a person, it has high localizing value. Okay, now what I would like you to see here is very subtle findings that are related to saccadic metrics, okay? When she looks to the right, slight overshoot, a little bit hypermetric to the right, slightly hypometric to the left, but the hypermetria is a little easier to see on this video. Okay, now when she comes back to primary, not bad, and then you'll see a little bit of hypermetric when she comes. See the little hypermetric saccade there? She's a little bit hypermetric to the right, and that's the hypermetric saccade to the right, slightly hypo to the left. Okay, now how do we kind of put all of this together? Now bear with me for this diagram. Diagrams like this can always be a little confusing, but remember this, okay, and I think this is where her lesion is, and this was her MRI. You can see that cerebellar left cerebral pontine angle lesion like we would have predicted with the Brunn's nystagmus. But what about the saccadic dysmetria? And I think this also helps explain this neuroanatomically. Remember here, you have, this is your dorsal vermis, right? And deep to the vermis, there are these two nuclei called the vestigial nuclei, one on the left and one on the right. The function of your vestigial nuclei, among other things, from an ocular motor standpoint, is to drive the eyes to the opposite side. So the right vestigial nucleus moves the eyes to the left vestigial nucleus moves the eyes to the right, both of them. Okay, so basically that's the function. Now, on top of that, you have the Purkinje cells within the dorsal vermis that exert an inhibitory effect on the underlying vestigial nuclei. Okay, so if I've got more activity, here on my left vestigial nucleus because I lose the inhibition. Okay, that means that I've got more activity on the left, my eyes are going to be driven to the right more easily. If the vestigial nucleus's general function on the left side is to drive the eyes to the right, and it loses its inhibitory influence on the overlying vermis, then it's going to do that job better. And that's the reason I believe in this case she has the right-sided saccadic hypermetria because of a lack of inhibition over the left vestigial nuclei. Okay, and then on top of that, we of course do cover-on-cover testing and so forth, and the adductions were fairly full. We imagined maybe a slight inferior oblique overaction on that right side, but there is a fairly comitant right hypertropia with a small esotropia as well, which helps, of course, explain her presenting features of a vertical double vision. And this was a skew deviation. You can see that this is far too far south or far too far down the brainstem for it to be a fourth nerve palsy, but this was a skew. And again, just to very briefly talk about a skew in this context, we know about our otolith organs, in particular the utricle. And in addition to the dynamic input that's there for interoral translation and fore-aft translation, there is a static position signal, which is what's relevant in a skew deviation, which means that my left utricle and my right utricle are in balance when my head is upright with gravity, okay? Now, when I tilt my head to the right, not pathologically, but let's say I tilt my head to the right. If I tilt my head to the right, my horizon now is tilted, but to counteract that, there is a partial offset where my right eye has to go up and has to encyclotorque because now my torsional poles are off center. So in order for us to normalize that, what the normal response is, a right head tilt causes the right eye to go up and encyclotorque and the opposite eye to go down and excyclotorque because it's all conjugate. Now, a right-sided head tilt is the same thing as a lesion on the left otolith organ because it's a relative imbalance, okay? So even though a right head tilt results in the normal physiological process to highlight the horizon, if I have a left-sided lesion, same thing as a right-sided head tilt as far as the brain is concerned, and therefore there's more activity in the right otolith, so that right eye will go up and encyclotorque. Now, we know the lesion, if it occurs before the decussation at the pontomedullary junction, you'll have a contralateral hypertrophy as we do here, okay? And one way to differentiate this from a fourth nerve palsy, and there's many other ways, but maybe not many, but other ways as well, is that we recognize that the higher eye encyclotorques and the lower eye excyclotorques, which is in contradistinction from a fourth nerve palsy, unilateral or bilateral, you are going to get excyclo of the higher eye. And this is kind of the diagram that we can show. And you can see her lesion there. And again, if this is on the left side here, there is a decussation at the pontomedullary junction and ascent within the MLF, but you can get a contralateral hypertropia with a predecessation lesion, which we have here. Lesion on the left, hypertropia on the right. Okay, so I wanted to just give those cases here, not because MS is particularly uncommon. Obviously, it's common, but we generally focus on the afferent deficits. We know that optic neuritis is the most common retrobulbar optic neuritis in this context, but it can involve the chiasm, the tracts, the radiations, striate cortex, anywhere along the afferent visual pathway can be involved. Ocular inflammation, also, although relatively rare, most reports will say between 1% and 3% of MS patients. Again, a hard number to really get our head around, but anterior uveitis, posterior uveitis, pars planitis, periphlebitis may be even more common than any of these, but they're there as well, as we can see. The efferent deficits, internuclear ophthalmoplegia, probably the most common. I wasn't able to find a paper or a article that was able to say, with the but of course, I think afferent is much more common. But we can see any cranial neuropathy, sixth nerve more common than third, more common than fourth. Nystagmus, as I've shown, you can see upbeat, gaze evoked in the context I just mentioned. Pendular nystagmus is also not uncommon, and that's usually in people who have an afferent deficit in addition to brainstem or cerebellar dysfunction due to abnormalities in the feedback loop between the afferent copy and the efferent copy. And supranuclear deficits, our patient demonstrated this well. The skew deviation could be pre-decussation or post-decussation. Incidentally, if it happens post-decussation in the MLF lesion, in the MLF, you can get not only an INL, but also an ipsilateral hypertropia, which correlates with the same localizing phenomenon. And the metrics of the saccade is very, very important as well, because hypermetria, generally speaking, localizes the cerebellum. Hypometria could be the vermis, it could be Parkinson, it could be a lot of other things, but hypermetria is actually quite helpful when you can see it. I hope that was helpful in the sense just to kind of highlight some things that we every day see, but if there's any questions or comments, happy to take them.
Yeah, Dr. Vivek, can you hear me? Yeah. So
yes.
Very wonderful cases to actually document the efferent findings. What I wanted to check with you is, do you get simultaneous afferent and efferent manifestations of MS?
Many times. I think many times I've seen patients who may present with an afferent finding, let's say, but they have efferent findings on examination. Generally speaking, because this is a relapsing, remitting disease, they may not come in all at the same time. But certainly many cases that you see for one manifestation may have pre-existing findings of afferent system. And I think that's why it's important. And sometimes you will see, to your point, and you're making an important point, because sometimes we think something is afferent, but it's actually efferent. I've, I think, on several occasions seen patients that come in with a complaint of reduction in vision. Okay, and of course, that's a common thing. Blurry vision. They may not even think that's oscillopsia because there's not enough of an amplitude of excursion for them to actually see the image simultaneously in two different places. But if there's enough of an oscillopsia, particular pendular, that is small in amplitude, it can just blur the image, and that's retinal slip, but it's actually an efferent manifestation. And that's, I think, sometimes something you see as well. So important to kind of keep the whole picture in mind when we see these patients.
And any specific features that help you differentiate with the other causes of
these presentations? Right. I think, again, global context, if you see other features that, make you think about an afferent disease with efferent, the history itself, I had in the past this or that. I like the fact that in cases, for example, with the upbeat nystagmus, right, paying attention to slow saccades is important. We know that in myasthenia gravis in general, they actually, the saccades start out kind of lightning. They start out kind of fast initially when they're rested, and then they slow down. But there isn't the same consistency that you see in a paralytic cause, which I think is nice to see there. The upbeat, you should certainly get upbeat nystagmus because of fatigue in myasthenia gravis as well. But again, a little bit different. We don't see abducting nystagmus with the same consistency in a pseudo-INO like we would with myasthenia gravis, but we see abducting nystagmus quite regularly. when there's an adducting deficit due to an INO. And I think the co-localization, as I was saying, if you have something with hypermetric saccades with a skew and so forth, you're looking for a lesion in that area. And then the lesion then is, of course, helped. We solve, and our differential is greatly assisted by neuroimaging, which is sort of cheating, you know, when compared to, you know, yesteryear. But we have that information now. And as John's case earlier showed, and others have shown, even with the neuroimaging, there can be some ambiguity. You know, white matter lesions are not all the same, but that's where the fun of it comes. But our patients, you know, eventually had further workup, and they had the oligoclonal bands and so forth. And I think that helps them secure the diagnosis.
And one quick thing regarding your first case who had bilateral gaze palsy, did the patient have any diplopia?
No, great question. It was so balanced at time of onset that it was literally his complaint was, I can't move my eyes. You know, he didn't try to move them up or down. He could certainly move them up or down, but he didn't have diplopia. And he was treated with IV Solu-Medrol in the clinic, in the emergency department very quickly. And that's, I think, helped expedite the improvement. But as far as I know, he didn't have diplopia. And if anything, very transient if things were improving and, you know, improving asymmetrically. And it's a good point because even in gaze palsies, sorry to interrupt you, but I've seen many gaze palsies in which the abducting deficit is not exactly the same as the adducting deficit, right? And it can be asymmetric. It doesn't be, it could be -4 and -3, -2 and -1, whatever it might be. And therefore there'll be diplopia. I think you could see in that acute onset video, it was quite limited either direction. So.
Yeah, because if it's asymmetric, you can get some amount of diplopia, which can actually be disturbing. And then how did the patient eventually respond to treatment?
Beautifully. I mean, I think the first and third patients who have less of a chronic course, I actually just saw the third patient very recently, maybe just a week or two ago. And she's doing very well. She's on a disease-modifying agent. She hasn't had any new recurrences or relapses, so she's done fine. And the skew deviation completely resolved. The hypermetric saccades, again, they were pretty subtle to begin with. And so I don't think that I could see much of it on the clinical examination, but she's quite asymptomatic now. RNFLs and GCC also stabilized. The first patient, he finished his PhD, computer science. He's off doing his thing. And he's also asymptomatic. So credit to the neuroimmunologist to kind of keep him in check.
So you were able to completely resolve the condition, I mean the bilateral gaze palsy?
Yes, and you saw that video. That video that I showed in resolution was, I think, just about 6 weeks after. And that my first time I saw the patient was about 3 years ago. So, you know, that was a fairly quick resolution, likely helped by the steroids and so forth. But yeah, he doesn't have symptoms currently.
Okay. So can there be any residual left back in case there's a delay in treatment?
Yes, there can be. Certainly there can be. And in some cases with INOs, for example, the lesion is destructive enough or damaging enough, in particular to the MLF or whatever pathway was involved. And sometimes, you know, as we know, the lesion that might show up is just off of the actual pathway, and the edema or swelling surrounding it in the acute phase is what causes the clinical deficit. And we always hope for those, in particular with strokes, right? Because we know that the ischemia is more damaging in that situation. But I'm always hoping that once the perilesional edema improves, there will be some improvement. But there are patients who have more of an epicenter kind of a hit, you know, on the substrate.
Yeah, true. So really interesting cases. Any other questions or comments from the panelists, other panelists?
Yeah, thank you, Vivek, for this great review of relative neuroanatomy here with pertinent cases, and also for emphasizing the dynamic nature of some of these lesions as they change. So for instance, with the INO, acutely, you can have this INO plus syndrome, which can have an associated upbeat nystagmus or torsional nystagmus and a skew deviation, and then it just settles down to an INO, and chronically, all that might be left is an adducting saccade and not much else, right? So there's an evolution over time. So actually, I always tell the trainees, take a video when you first see the patient, because you might be seeing something different than the attending will be seeing the next day, right? And it's just to document this evolution. And I actually thought that your first patient on the recovery video had some slowing of the adducting saccade. So he probably had a little component of INO that wasn't evident because of the gaze palsy that he had.
Yeah, that's a great point, and they do tend to change. And I think Dr. Matalia was getting to the point is that the resolution of the various findings may be different, right? And something may completely get better. A vertical deviation is obviously very hard to fuse. So if there's some residual skew, that will be symptomatic, and the patient will continue to complain of that. But a small amount of a horizontal may be overcome by their fusional amplitude. So it's a good point, and these things evolve. And I think that's why when we see these patients in follow-up, it's important to not just look at their GCC or RNFL and go, you're stable, because there are things. And I think on many occasions, people who have been stable and no more lesions or no change in their lesions have something that we didn't document last time, like slowing of saccades or some hypermetricity of their saccades or so forth, that I can only really be sure wasn't there last time if I checked it last time, because it may not be something the patient is complaining of. So that transient nature of it is important too.
And I think it helps with the differential diagnosis of things of optic neuritis. If you see somebody with optic neuritis and they have some slowing of adducting saccades, it's probably an MS patient and not an NMO or MOG patient, right? So looking for these subtle clues, it can be very helpful.
And I think, as rightly said, we should take videos of this so that subsequently we can go back and see if we've missed something, or follow them up to see if we are, so how these eventually improve over time or anything is residue.
Agree. And I will say this, you may be already doing this, but I'm not necessarily the most computer advanced guy, but one of my previous fellows, she had mentioned to take slow-mo videos, and I do it all the time now. So any with nystagmus or adducting velocity, whatever, where you're trying to see difference in changes for rate of movement, it can be hard sometimes. And if I had done any of those hypermetric saccade videos in slow motion, I think it would have been easier to see the overshoot much more so. So there's just that little slide of the button on your phone. And I found it to be helpful in certain cases where the findings are a bit subtle. Even the waveform for nystagmus comes sometimes for a high frequency nystagmus can be hard. And if you slow it down, you can see that. I find it helpful in the patients who have a Wallenberg syndrome, where you're looking for ipsipulsion or contrapulsion on vertical movements. If you slow down the video, you will see this elliptical movement much more easily than you would just by having them look up or down.
Okay, right.
Yeah.
Dr. Patel, a wonderful case is just a quick point, a small comment and question. So comment is that you mentioned about the various forms. I think given the tracts that are going that can get affected in the brainstem, we can have various forms. I have seen even a periodic alternating nystagmus following MS. And the question is that for these patients who have acquired nystagmus secondary to MS, apart from the neuroinflammatory disorder, for alleviating the symptoms, would you be using specific drugs like for upbeat nystagmus or for downbeat nystagmus to make the patient better?
Yeah. So as you know, there is the classical kind of teachings about certain medication stuff. And I will humbly say that I always find that it's very hard to find something that works in these patients. I think that it's classically mentioned that for periodic alternating, for example, hopefully if it's an MS patient, the PAN gets better as the lesion resolves. But if it's something more chronic, baclofen tends to be more helpful in those situations than others. Gaze-evoked nystagmus, downbeat nystagmus, 4-aminopyridine may be the best option we have. Again, underwhelming in times for me in terms of what we can get in terms of tolerability, but 10 TID is what I try to help them, get up to. And in our country here, it has to be formulated as a compound pharmacy because Empira, which is the MS medication for gait, will not be covered for nystagmus. Patients with pendular nystagmus, they generally speaking may get some improvement on gabapentin, but usually very large doses, 1,800, 2,100, 2,400, and slowly get up there. I feel like the typical dose of anywhere from 600 to 900 milligrams of gabapentin does not help these patients. I have some patients, as I'm sure you do as well, with oculopalatal tremor that have a disturbing kind of dissociated vertical torsional nystagmus. And I have some that will swear by it. I have one patient that she went with her family to a cottage. she drove back or had somebody drive her back because she forgot her pills. So, I mean, it may be a placebo effect, but there's some help there. But nystagmus is hard, but it's helpful to have those categories to know what could help. So I always try, but.
Thank you.
Okay, thank you for inviting me.
Thank you. With this, we'll move on to the last case for this session. And we have the last case being presented with us by Dr. Helen Mayer. She is Sir William and Lady Stevenson Chair in Ophthalmology, also the head of academic neuro-ophthalmology and glaucoma services at University of Auckland. She has published over 200 papers in the field of glaucoma and neuro-ophthalmology. She has authored several textbooks and chapters. Her interest areas include imaging modalities in neuro-ophthalmology, giant cell arteritis, ischemic optic neuropathies, the role of astrocytes in optic neuropathies, and glaucomatous optic neuropathy. She is pursuing research in chiasmal compression and role of connection in brain injury. I think she is unable to join in person, but she has sent a recorded presentation. Dr. Satya will play that, and Dr. Rebecca will be leading the discussion for the recorded presentation.
Yeah, thank you, Dr. Virender. Yeah, actually, unfortunately, she's traveling. So she has sent me a pre-recorded video of her case presentation. So I would like to share the screen and present that on her behalf. So I think my screen is visible now.
Right, it's visible. You can go to screen.
Mistaken identity.
Slideshow.
Mrs. AJ is a 65-year-old woman who presented to me after seeing a couple of other ophthalmologists. She had difficulty focusing when looking down. In particular, she noticed when she was crossing curbs, it had become more and more difficult over the last 2 years. She had increased blinking and her eyes felt dry, and she had more difficulty focusing when her eyes were moving quickly. For example, when she was driving, after a while she found that things started to go out of focus. She was diagnosed with dry eye and ocular surface disease and treated with lubricating drops, which helped a little bit, but not completely. Over time, she developed a subtle left ptosis and went to see an oculoplastic specialist for consideration of ptosis repair. The oculoplastic surgeon was not convinced that it was a simple ptosis because he noted increased blink rates and some features of blepharospasm, but he did not notice any diplopia. So he referred her for a neuro-ophthalmic assessment. On reviewing her history, she commented that she had noticed a weaker voice, but no particularly dysarthritic speech. She had some difficulties with swallowing solids, and she just said she noticed she had to eat a little bit more slowly. Her tongue felt hard and dry on questioning, but there was nothing that she offered spontaneously. She noticed that she was dragging her left leg a little bit more and went to see a neurologist to see if she had any features of Parkinson's disease, but the neurologist cleared her of any underlying neurological deficit. Her past medical history is that she had recent COVID, but nothing became worse after her infection. She lived with her husband. She had 4 children and 9 grandchildren. She had a distant history of smoking 40 years ago, which she had a 10-pack year smoking history. She has a strong family history of autoimmune disease, including Hashimoto's, and she has a daughter who had Guillain-Barré syndrome and a brother who had IgG4 disease. On examination, she had left ptosis. Her eye movements were actually very difficult to elicit any abnormality, and I'll show you a video in a moment, but she may have had some slowing of saccades on repeated testing and some weakness of her orbicularis oculi. Neurologically, she had no wasting or fasciculations. Her power and tone was normal.
I guess there's some problem with the
Yeah, video is not playing that well.
yeah. Although I did try it at home and it was playing pretty well. Let me just go back and check my mail.
Hello, my name is Helen Danish-Meyer, and I would like to present an interesting...
I'm very sorry for this issue, but I did try at home and it was playing pretty well.
Would you like me to run it from my
Yeah,
computer?
if you have it, sir, if you could play it from there, yeah.
Okay, I'll do that.
Thank you, sir. I'll stop sharing then.
Okay. Is the video visible?
Yes, Dr. Hatta.
any underlying neurological deficit. Her past medical history is that she had recent COVID, but nothing became worse after her infection. She lived with her husband. She had 4 children and 9 grandchildren. She had a distant history of smoking 40 years ago, which she had a 10-pack year smoking history. She has a strong family history of autoimmune disease, including Hashimoto's, and she has a daughter who had Guillain-Barré syndrome and a brother who had IgG4 disease. On examination, she had leftosis. Her eye movements were actually very difficult to elicit any abnormality, and I'll show you a video in a moment, but she may have had some slowing of saccades on repeated testing and some weakness of her orbicularis oculi. Neurologically, she had no wasting of fasciculations. Her power and tone was normal. Her balance was actually normal, as was her gait, and she had absent reflexes symmetrically. And here's a video I shared with her permission. So you can first see that she has quite easy, she can squeeze, but her orbicularis is not quite as strong as I would normally expect. There was no clear cranial nerve palsy. Just get my pen and follow it slowly. There was no cranial nerve. Now I want you to look at my nose and the pen. Nose, pen, nose, pen, nose, pen, nose, pen, nose, pen, nose, pen. This way. Pen, nose, 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 pen, nose. Squeeze tight. So you could see from her eye muscles that she really did not have any clear cranial nerve palsy. There was the leftosis, slight weakness of her orbicularis, and I thought that she had some saccadic dysmetria on fatigue and some slowing of her saccades. There may have been a subtle suggestion of a Cogan's-Lee twitch, but it certainly wasn't an obvious one. So her examination findings were quite subtle. Her symptoms of dry eye and dry mouth, as well as her 4 to 5 year history of limb fatigue. So the differential at this stage I thought was myasthenia gravis, most likely, but also we always need to keep in mind myasthenic syndromes. And there are other possibilities that we should be considering as well. And perhaps we can discuss that later. So the initial investigation she had already was an MRI of her orbit and brain, which was normal. And acetylcholine receptor antibodies, which we organized, were negative. The tensilon test is no longer readily available in New Zealand, and I would be interested to see what the rest of the panel's experience is with having access to tensilon testing. So we usually go to single fiber EMG in the scenario. We did undertake an ICE test, but it was equivocal. It wasn't hugely reliable or repeatable when we did it on 2 occasions. So the single fiber EMG is really what gave us our recording and findings. So the recording electrode is placed between 2 fibers that innervate the same axon. This is just review. And the delay between the action potentials relates to the delay in transmission across the neuromuscular junction, which is a jitter in microseconds. And so this is increased in Lambert-Eaton myasthenia due to impaired neuromuscular junction transmission. The jitter is the most notable at low firing rates and then partially improves at higher firing rates. And here you can see her results, where A is stimulating the median nerve at the wrist, and B is stimulating at the elbow, and D, you can see what happens after exercise, 10 seconds of exercise, and then E returns to normal, back to the low amplitude after 30 seconds. So this facilitation is dramatic and is reported by our neurologists who undertook it to be approximately 400%. And this is characteristic of Lambert-Eaton myasthenic syndrome, but botulism can produce an equal response. So based on the single fiber EMG, a diagnosis of Lambert-Eaton syndrome was made. So then became the challenge of trying to identify the underlying cause. So the most common cause, or the one we tend to think of as a paraneoplastic syndrome, and it's related most commonly to small cell lung cancer. However, other cancers can produce a Lambert-Eaton syndrome picture. Interestingly, 40% of Lambert-Eaton are primary autoimmune disorders, which have a similar course to myasthenia. So the pathology is different than myasthenia in that the antibodies are actually targeted against the voltage-gated calcium channels on the presynaptic nerve terminal, as opposed to myasthenia, which is on the postsynaptic nerve terminal. But as a result, the release of acetylcholine neurotransmitter is reduced. So this is just to remind us of what happens in a normal neuromuscular junction. So we can see here that the voltage-gated calcium channels cause opening and allow an influx of calcium into the presynaptic terminal. So this calcium then binds to the vesicles, which then make their way to the cleft and release acetylcholine. So the activated vesicles fuse with the presynaptic cell membrane, causing the release of the neuromuscular transmitter into the cleft. In Lambert-Eaton, you have an antibody produced against the calcium-gated channels. And so this blocks the normal influx of calcium, and therefore acetylcholine release is not sustained to its normal levels, producing the myasthenic-like picture that we see. So the clinical features are that Lambert-Eaton can precede the diagnosis of cancer by 5 to 6 years. In Our Lady, her screening test of CT of the chest, pelvis, and abdomen was negative. And her antibody test for, then you do a voltage-gated channels for the calcium channels came back positive. Her PET scan did not show any underlying cancer at this stage. So it still remains unclear as to whether she has the paraneoplastic syndrome with the cancer yet to present itself, or she has a primary autoimmune condition. The other symptoms on retrospect in reviewing this case, which are more suggestive of Lambert-Eaton, are the proximal muscle weakness and the progression from proximal to distal, and then the cranial nerve involvement. When the ocular bulbar symptoms are involved, which occur in 70%, ptosis is the most likely finding, and then the bulbar symptoms are quite relevant, the dysarthria and the dysphagia. One important clue in this case was the association of dry mouth and dry eyes. And if you have a patient who has these symptoms in combination with features that you're thinking of myasthenia, please think of Lambert-Eaton syndrome. The other autonomic symptoms that patients will complain about, although our patient did not have, are constipation, orthostatic dysfunction, and altered perspiration.
Again, the areflexia is an important clue in this case as well. So as we talked about, the diagnosis is really single fiber EMG, shows the post-exercise facilitation, which is the hallmark of Lambert-Eaton syndrome. The investigations, as we have also mentioned, should continue, and even if a patient has a negative test, does not mean they should not have ongoing investigations to see if a malignancy does not appear later on. And in terms of treatment, the treatment option is 3,4-DAP is the primary treatment for this, and this blocks presynaptic potassium channels, prolonging the action potential duration and allowing more influx of calcium into the channels that are not blocked. Of course, you can try acetylcholine inhibitors as well, such as mestinon. And in New Zealand, we are obliged to try mestinon first before we can apply for 3,4-DAP. Immunosuppression is also a possibility. IVIG has been shown to have some reported results. Steroids also potentially have some role, but other immunosuppressants have not shown to be that helpful. Rituximab potentially has a role, as that it is theoretically effective against all B-cell mediated diseases, but the evidence for this remains minimal. Thank you again, and I look forward to the discussion on this case.
Over to you, Rebecca.
Yeah, thank you, sir, and thank you for the timely save. So I think it was an excellent talk, and it covers most of the discussion. So what I understood basically from this case is that, just like myasthenia is a great mimicker, you have very non-specific symptoms in Lambert-Eaton myasthenic syndrome. So very non-specific muscle weakness that the patient had probably a few years back, went to a neurologist, even neurologist evaluated for, Parkinson's in this case, and it was ruled out. So a very non-specific dryness of eyes, again, non-specific symptoms. So it's only when the eye symptoms started, like ptosis and diplopia, that they really started thinking about something else. So although they say that ocular bulbar involvement is the last to happen, usually Lambert-Eaton syndrome starts from the caudal part and then moves towards the brain. So ocular bulbar involvement is pretty late. And despite that, it's essentially presenting with very non-specific things, and the significance of diagnosing it lies in the fact that most of these cases may be paraneoplastic. So, and I think one question that Dr. Helen put up has been already answered about the tensilon test. Most of the panelists have already put in their view. And I also concur with that view that regarding the tensilon test, it's not available here with us, at least at RP Center in Delhi. So what we do is an IcePack test for ptosis. If not, then we go ahead with the neostigmin test. So that may help in differentiating between myasthenia. However, I think it is the high index of suspicion in these cases that we have to think about. You have to keep a high index of suspicion, only then you can think about testing for these alternate. Otherwise, clinically also, you can differentiate myasthenia from Lambert-Eaton just by eliciting the history about a post-exercise facilitation. So maybe that can give you a little hint and help in differentiating the two. So if other panelists have had the experience with a similar case, if they would like to share.
I think, Dr. Rebecca, you pointed out great points. I think it has to be kept as, again, a diagnosis of high suspicion, and the characteristic findings and the workup that will be needed will be important. Having said that, I have never seen until now a case. All knowledge is theoretical, but we have Dr. Miller, we have others. They can share their experience.
Absolutely.
Well, my experience is similar to what Helen had said. You have to have a high index of suspicion, and the key is the fact that it's not a decremental response, but an incremental response. It's also interesting, one of the sort of subtle keys perhaps to that diagnosis, Helen thought that the saccades were a little bit slow, but actually in myasthenia, they're actually, if there is any limitation at all, they're actually hyper, because the main sequence isn't correct. And so you have let's say you're making you want to make a 20-degree saccade. The the eyes are limited, but the velocity is triggered for a 20-degree saccade. So you make a 15-degree saccade with a higher velocity than normal. So I couldn't tell if the saccades truly were limited, but if they were, that would suggest, however subtly, that this was something else. You know, Lambert's first case, as I recall, did have, traditionally, Lambert-Eaton didn't have any eye movement abnormalities, except that if you go back, Lambert's first case actually had, I think, ptosis as part of it. But subsequently, all the cases of Lambert-Eaton have basically subtle abnormalities of saccades and pursuit, but nothing impressive.
Right. So it's actually such a rare disease that even I did not have an experience seeing such a case as Dr. Virender has told. So that's why I would like if other panelists would like to share any other thought about it.
Yeah, Dr. Rebecca, I'm Vivek here. So I just wanted to, like what we have been taught when we do a neostigmine test, if there is a kind of, the paradoxical worsening, then we suspect, the Eaton Lambert. So what's your thought or, the other panelists' thought on this? But I have never had, like turning up these patients on retrospectively looking at, they are not at all a rare possibility of the Eaton Lambert. But we do see normally, even if we wait for more time, like more than 10 minutes, we do see that there is a fasciculations, and probably that's a part of like the receptors are being now engaged by the acetylcholine.
Right. Yeah, so maybe, we have seen a lot of cases that look like myasthenia. However, on antibody testing, we find it to be negative. So probably these are the cases where we should, think and go for further, further testing about the related to Lambert-Eaton syndrome.
Hey there, I just thought I could just comment in just because Lambert and all that was at Mayo Clinic. So we do get some of these referred, from pretty far away. That's so rare. But, I think there's so much overlapping features, but as, everyone said, the eye findings are usually the more minimum ones that, if they do have a good amount of autonomic dysfunction, again, dry eye, dry mouth is not that specific, but if it's a male and they have impotence, or if they have problems with urinary constipation, maybe less specific, but, a male with impotence, maybe that can make you lean toward maybe an autonomic dysfunction. And again, that proximal weakness, they often describe, difficulty getting out of a chair, and that can make you lean that way. But again, for us, we just, I think you can just check for the antibodies. If they're seronegative for the acetylcholine receptor antibodies, then you can check for the voltage-gated channel antibodies. And of course, your EMG, that's going to be really, really helpful. And so, our seronegative myasthenics, we're getting single fiber EMG, so that'll give you the answer there too. I agree with all the wonderful comments from the experts.
Thanks, John. I think any other comments on this case by anyone? Okay. If not, I think we'll conclude this session here. I hand it over back to Dr. Karna for proposing the vote of thanks and concluding the meeting.
Thank you, Virender. And while I set up a slide, I request everyone to put on their videos so we could have a great group photograph. Few more. Yeah, that would fill up the screen. Okay, thank you. I'll share a screen now. Yes. As we come to the close of the 4th Global Neuro-Ophthalmology Case Festival, it is my honor and privilege to extend our heartfelt gratitude to everyone who has made this event a resounding success. Firstly, we extend our sincere thanks to all the faculty members who took time out of their demanding schedules to share their invaluable cases with us. Your contributions have enriched our discussions and deepened our understanding of neuro-ophthalmology. We truly appreciate the encouraging response from viewers across the globe, which reflects the vibrant and engaged community we have. To our esteemed speakers, panelists, and moderators, we are deeply grateful for the enthusiasm and expertise you brought to our scientific deliberations. Your insights and dynamic interactions have been instrumental in making this festival both enlightening and engaging. A special note of appreciation goes to Sunilji, our webmaster, whose intuitive and professional handling of the technical aspects ensured a seamless experience for all participants. Your efforts behind the scenes have not gone unnoticed. We would also like to express our gratitude to Entod Pharmaceuticals for their generous support and facilitation of this entire event. Your partnership has been crucial in bringing this festival to fruition. Looking ahead, we are excited to welcome the experts and delegates who will be joining us at the Indian Neuro-Ophthalmology Society Annual Conference in Chennai next month. We look forward to continuing our collaborative journey in neuro-ophthalmology. Thank you once again to everyone involved. Have a wonderful day and a restful night.
Thank you.
Thank you.